Thank you very much. Welcome. My name is Nick. I'm the events coordinator for the Center for Community Health and Engaged Research. We've been doing these workshops, I think, for 7 years now, 8 years now. We put on at least 5 of these public health workshops every year. We try to do them throughout the community of Arizona. We do one down in Yuma. We've done a couple at the Phoenix Bioscience Core campus throughout the past couple of years. This is our first time here at Banner Medical, which is really great. It's always nice to expand our partnerships. But I just want to say thank you to John Garcia from the Arizona Biomedical Research Center within the Arizona Department of Health Sciences. You all live in a world of acronyms, so I'll just throw out acronyms. But we have, like I just mentioned, this is the 4th of 6 workshops we've hosted this year. My cheat sheet. Back in October, we did a Science of Community Health Workers Sustainability Conference, which focused mostly on CHWs and their ability to bill through Medicare and Medicaid. That was a 2-parter. So we focused on Medicaid billing back in October and then transitioned to Medicare billing again in March. And so that was actually a very successful workshop we did with Dr. Sam Sabo at NAU. We always like to support our CHW workers, especially being up in Northern Arizona, a lot of rural communities up there. But then the second workshop we actually did in November, which was innovative approaches to enhancing the behavioral health workforce in Arizona. That was also a very successful workshop, headlined by our director, Julie Baldwin. And so we'll actually be working with her again next week on April 8th and 9th. We're doing a culturally centered addiction research conference in Flagstaff. I will share all that information following the workshop. So if you'd like more info on that, I can get that to you. And then we're going to be wrapping up the year on April 14th down in Yuma. It's back-to-back workshops. But Yuma's great. We work with former State Senator Amanda Aguirre down there, and she is basically building an entire community in San Luis, Arizona. Hospital, medical systems. They're having to build fire stations and police. It's really incredible what she's doing down there. But this will be our 8th annual Yuma conference coming up. And so that mostly focuses on border health. And this upcoming conference is going to be how the community has reacted to the Big Beautiful Bill. What are some challenges? What do they anticipate kind of moving forward? And so I will post all of these, and I'll actually be sending out a post-workshop email to everyone. And it'll have the list of these workshops, the links to our Share YouTube page. We record all of these, and they become basically a public resource. So thank you all. That's all I'm going to say. I'm really looking forward to this. Was back in December when we did the ASU Business and AI Summit, and I learned a lot about AI, and it scared me at the same time. But I'm really excited to hear from Frankie and Leo and Bree and Michael. So yeah, thanks again for coming. Please help yourself to coffee and snacks. We also will have some grab and go lunches served around 12:15-ish. Yeah, thanks so much.
Well, I will start us off. We're going to change the schedule a little bit. Wow, I had no idea that any of you did all that teaching. That's incredible. Well, sometimes the enemy of good is perfect. I mean, perfect. It really is. That works. I would have liked to have participated or listened in on some of those Medicare. I'm going to talk about that. And I have 2 things. One is to thank John for all of the funding and the support. We now call that Arizona AI Wellness Hub, which I know is going to be just a fantastic thing for the state. And to thank Michael Liu from Harvard Medical School for being here. You are going to be blown away by the quality of the talk and the pressure. And I was thinking in the car when I was picking up Michael that maybe we will repeat something like this on a grander scale, this time next year, to kind of drive home some of these things for the people who want really lock down on AI and perhaps a combination of AI and funding for AI, some of the things that I've been. So I do not have any disclosures to report. I am the former CMO of Element AI and Imagia. Was non-medical, and Imagia was the medical spin-off from the Montreal Institute of Learning Algorithms. But I do want everyone to be wary of speakers and promotional material that you get in there. I'm not going to give you any of that. But it's, you never know when someone's looking at it. Maybe we should turn the lights out. Or does anyone see anything in peculiar on this famous artwork from Milan? See, there's always always someone looking. So let me give you a little brief perspective. And this is what I call the common denominator. So if you go to the Rockies, and this picture is actually from the Canadian Rockies, but it doesn't matter. And you see, the salmon run, and you see the bear eating the salmon. It's not like the cartoon where, the bear puts the fish in his or her mouth and then just out pops the skeleton. So does anyone know exactly what the bear's doing there that hasn't seen this slide before? Any thoughts? He's tearing the skin off. Good. For why? To get to what meat? What's in the belly? You're on it. Yes. The bear, and you're one of the first people that's ever got it right. The bear just eats the caviar. There's so many salmon that the bear, boom, eats the caviar. Boom, eats the caviar. And the carcass, the 95% of the fish just gets thrown out. And it happens over and over again. And then there's just crazy numbers of birds all over that are just, taking the other 95 or 98% of the meat. Well, the reason I show you this is what we do in radiology. We have jillions of images that come to us. We extract this tiny little 1% that we're supposed to do, normal appendix, and we throw away 98% of all of the information. And the whole point is to try to extract more information out of the fish, or to, if you will, eat more fish. And that is, what can be good about AI. And if you remember nothing else, remember that, we're limited in what we could do, and we have our assignments of the things that we can do. And so what the technology allows you to do is, if it's working the right way, is it allows you to eat fish. There's all kinds of, these are the three graces. This is actually a sculpture that goes back and forth between DNA Museum in Edinburgh, and these are people who really don't care how their medical information is being used, but most people do, and most people care about how their information is being used, and most people want to know how their information is being used. And there are lots of disclosures that we can and should make. In the state of Texas, Bill 8122 is passed, where any provider who uses AI in any way in the patient's care now has to disclose to the patient that they're doing that, which is something that is a really interesting thing, and it could very easily creep west to Arizona. I wouldn't be surprised if something like that became more apparent. So you have to think about how we're doing these things and how we're discussing that. And there's a lot of regulatory issues in AI, and they're mostly trying to keep AI in the realm of things that are going to be used for good. At the same time, some people think that those exact same regulations are hindering, people from using more tools and developing more tools. Different people have different opinions. Although I'm very favorable on the FDA, I do have some criticisms about some of the way some of these things are happening. Talk about that. So typically people show different circles, and you see, learning and different, you've probably seen those before. I don't do it that way. And we didn't do it that way at Imagio. We just kind of thought, okay, what is intelligence? And then how can artificial intelligence kind of be involved in that? And so this is the way that I think about it. And if anyone, I guess now this is a public document, it'll be online, but if anyone wants a copy of the slides, you just email me. Anyone can have any of my slides. And there's nothing secret about it. So you don't have to take pictures or do screenshots. So, there's perception, kind of the computer vision world of AI. You've got communication, and everyone's pretty attuned to large language models. You have reasoning and decision-making, kind of clinical decision-making and clinical decision support kind of falls in that realm. And then you have kind of interaction. So these are the things that we try to, and obviously people interact. You talk to someone on your phone that's, some type of bot, and they try to do for you whatever it is that you're asking them. So this is the way I think about kind of the actual components of intelligence and how we can interact with them. And kind of these are the research fields that kind of go along with that. Those are computer vision, speech, NLP, and robotics. We'll talk a little bit about each one of those things and how they interact in the healthcare sector. Each one. I'm going to leave this to Dr. Shepelev because this was a follow-up of his slides and we switched talk. He's kind of giving kind of the real basic, really deep basic kind of talk. And he will be here a little bit later. He's in an Uber because he worked all night last night and he was so busy cleaning up his cases that he had to get in an Uber here. He's still in it. This is a money dress, also something from Oxford. It's quite an incredible piece. But these are if you're very, very new to AI and deep learning, these are the basic fundamental steps, right? And that is data collection and preparation. So you have to have good data and you have to be able to prepare. And some of the big challenges that we have in, I would say, non-large language model tools that we're developing now is that data preparation. For example, one of the biggest barriers that we have in the radiology space is that when we want to prepare data, we have, for example, CT scans. We have CT scans from all different vendors, and they all have different reconstruction thicknesses. They all have different kernels. They all have, a proprietary DICOM header. And all of these things need to be overcome when we actually get data prepared and we're trying to use that in a meaningful way. It actually would be a lot easier if there was just one CT scanner and everyone got 1 millimeter slices for everything. We'd be so far ahead of where we are right now. But data collection and preparation and the regulatory piece and the informed consent is a real big part of it. And I do believe Michael's going to talk about that a little bit. We have model training, and that is when the, in this case, neural network is trained using that prepared data. So we do training, we then evaluate and validate those models, and then we deploy them. And we can't just deploy them and not look at them. Right now, you can purchase tons and tons of services that are AI based. The most successful ones in our part of the world, and if you ask kind of Banner Corporate, what's the single most successful thing that AI has achieved in the Banner ecosystem? I think is Banner the largest employer in Arizona? Someone said that to me. It might be the largest employer. If that's wrong, you can kind of scratch the tape on the recording. But if you went to the C-suite, you asked Banner, they would say, does anyone know what's the single best thing? What's this Banner will say, what's the single best way that we've deployed AI in the Banner ecosystem? Except for Michael, because we talked about it. But, anyone in the audience? Online? So the single most useful thing that Banner will say is AI scribes. And so the ability to not have a scribe there and to have the conversation with the patient and then just fixing the report. Michael may or may not show you a slide about how great it really is, but we think it's fantastic. And that's the best that we can do. The only AI tool that I have right now that I consistently deploy throughout Banner is the large vessel occlusion for stroke. And it's not because the radiologist can't find large vessel occlusion. The reason is because the stroke team can actually see it on their cell phone. So it's not actually the detection so much as the communication piece. And that's the only thing that we actually use and deploy. Now, we might move into the pulmonary nodule space, but we have to continuously watch things that we deploy. We have to continually evaluate the things that we deploy and make sure that they're useful, that they're cost effective, and they're not actually making more work. Because I will tell you that people who are paying for AI think, oh, your job's so much easier. We're just going to pay you less. Well, that would be great if the job really was easier. But a lot of times when we deploy a tool, it's just as much work. And maybe people would argue that if you deploy things wrong and you don't follow it the right way, it could be actually more work. Those are just some examples of each one of those. So when you think about problems for AI to tackle, you want to think about the good problems. A good problem is specific and controlled, and where there is training data, there's a low cost of failure, and there's an opportunity to test. And so this picture's not as high quality as the other ones because this one I took with my own phone. But this is the Pieta in Milano, and this is Michelangelo's last. And as you can tell, it's not done yet. And I actually made this slide before the 60 minutes. I made this slide a couple years ago before the 60-minute segment. There's actually been a 60-minute segment on this piece. If you're a fan of 60 Minutes, you can go back and watch it. So Michelangelo was a recluse. He didn't let anyone in when he was doing any of his work. So no one knew what he was doing or why. And he clearly had a change of heart somewhere along the line because there's an extra leg. And we don't really know if originally Mary was going to be on Jesus's back or Jesus was going to be on Mary's back. And so this has turned into an AI problem. Like, what was Michelangelo actually thinking? You can have all of the data that Michelangelo ever did, all of the scholarship that Michelangelo ever did, and try to figure out. Go watch the 60-minute segment if you're a fan, but no one really knows which one is which. So it's actually a really good problem for AI, which is why it was featured in 60 Minutes. It's specific and controlled. There's training data. There's the opportunity to look at results. And there's zero cost of failure, right? It's a purely academic exercise. But we want to pick good problems. We don't want to pick bad problems, because if we're going to use these tools for good, we want to be successful. What are ideas of good problems? We can think of some. Does anyone have any thoughts about good problems that we can solve in Arizona? I have one that I thought of ever since Michael and I drove in this morning. Apparently, what was it? What employee number was your brother in? He was the employee number 30 at Tesla. He was employee number 30 at Tesla. So that's pretty good. And we were talking about Waymo. So here's a really good AI problem. Here's a really good problem that could be integrated into Waymo, which is Waymos can be deployed. Everyone who's in Phoenix knows how stinking hot it is here in the summer. So one AI problem for good is a partnership with Waymo where we just deliver hydration. Literally just have Waymo have bottles of Gatorade that go into Waymo and get deployed at the time of when cars are being used. That would be a great AI problem for good. And, that could be a very good partnership. And I was thinking about that as we were walking up the stairs, because we're just talking about Waymo. Apparently Waymo's not as successful in other states as it is here. We love Waymo. So if you're from Phoenix, you'll see Waymos all over the place. You made it. In one piece. I'll go quicker now because Leo's here. So let's go into part two. So let's talk about the executive branch. This is the former executive branch. I don't know what your politics are, nor do I really care. But in the Biden administration, you saw this executive order. Has everyone know about or seen this executive order? So this is the reason why many industries, including the medical sector, started to get serious about different ways that AI would be managed. And this was before executive orders were used in a much more frequent way. There weren't a lot of executive orders, at least in 2023. There was a lot more of them, in the modern era. You can read about it, how there were 270 days from the date of this order to actually do all of these things. Develop a safe, secure, trusty AI systems. The Secretary of Commerce, the NIST, Secretary of Energy, and Secretary of Homeland Security were all going to do this, in the name of, national security and doing the right thing for trustworthy AI. After that, the NIST developed all of these pillars and all of these pathways. And if you're wondering kind of where the field has gone and why it's come that way, it's because of these pillars, right? It's this map, measure, manage, and the governance. I always get weary when you have things like this, like map, measure, and manage. When you see this thing like in the boardroom or like in Congress, like it can apply to anything. So if you're a Little League coach, you map, measure, and manage, right? And if you're the president of the United States, you map, measure, and manage. But I think the order and the design, some of the details were at least reasonable in developing some type of standards and how some of these things would be controlled. Knowing that in the medical sector, that kind of control and that kind of regulation is much more strict just because of the sensitivity of the medical data and the presence of that. And then a lot of the ways that the government thinks and thought about that was, okay, what is the possible harm to the people? What is the possible harm to the organization? What is the possible harm to the ecosystem? And that's why we titled this AI for Good. Basically, this was the slide that I had in my mind. It was also one of our company's logos that we were going to use AI for Good. So we kind of stole it from that. But this was the kind of the thinking about it. Like, make sure that you avoid all of these things. And I'm sure that you can come up with different examples of how things could be harmful. So in the medical sector, Chai spun out, I think, correct me if I'm wrong, but it was kind of Stanford, Mass General, Brigham. Was MGB part of Chai, Michael? I thought they were. I know Mayo was. I know Stanford was. So they came up with this kind of, they took the NIST infrastructure and they just applied it to medicine. And they made, they changed the logo a little bit, right? And they made, the different tiles, and they were applied to the medical sector. So if you're thinking about this in the medical field, this is one of the ways that you can evaluate AI tools and use them. And I'm going to go through just to give you a sense, and then we can talk about how this wellness hub kind of integrates. I won't go into all of the specific risks, but you can imagine that there's all kinds of potential problems that you can have. You can have bad data, training, you can ask the wrong question. There's this concept of drift that's important for people to know. Do people know what they mean by drift? I'll give you a simple example. That's Boston to here. So if you're training something on a chest CT and you want to evaluate CT, we see calcifications in the thorax. And all of those calcifications are from students from cocci. Right? They're all cocci. Well, in New England, there's no cocci. Right? In New England, you've got pleural calcifications or all different kinds of calcifications from, asbestos exposure, in the pleural space. And so if you're looking at trying to decipher what is a calcification, you need to train on that data. And if you have, if you actually have a different population, you can actually start training things. And you'll think calcification is one thing, you take that model and you apply it somewhere else and it's something else. It's kind of in the spirit of the concept. What truth is. And then RSNA, or the big radiology meeting, last year, we were all hanging around, and Mr. Elon Musk posted this: try submitting all of these things to Grok for analysis. I was in Chicago, my phone went off like a Christmas tree of the number of people in Arizona who were requesting all of their medical data and all of their imaging on CDs or on other formats. And it was just, they wanted, let us know, gets it right or needs work. So one could argue that that might not be the best way to use medical data, deploy it, and train, and then. But that was real, and I got it. I screenshotted it. It had been out for, you could see, I had been out for 22 hours because I was in Chicago, like I was like doing the whole radiology thing. And I was able to take a screenshot at 22 hours. It was about then the kind of the flood of people realized how to actually get that they could get their data from the hospital. So perhaps a place where we could. So most of the, this is kind of an old slide, but most of the things in the medical sector that go through, that are AI based, go through the FDA. And this is a copy of their website of AI or machine learning enabled medical devices. And actually over 3/4 of those are in the radiology space. The second most common field is cardiology. And so we really are kind of at the headline of the deployment of AI. Skip this slide. That should say 2026, but from the FDA, we actually go to the billing. This is what CPT is. CPT is the way that we actually code medical procedures. So if something is a medical procedure in the United States, the definition of that is that it has a CPT code, 5-digit code that describes what it is. So paracentesis has a CPT code. Evaluation for psychiatric distress has a CPT code. A visit to your family provider has 5 levels of CPT codes. So level 1, level 2, level 3, depending on the complexity of the amount of time that the person's spent. And that all goes to CMS. And what CMS does is then it adjudicates and it assigns value to all those medical procedures. And it's a big question mark of how the use of AI tools is going to be either assigned a value, not assigned a value, or how it's going to influence, because so many things are basically working through the AI space. And so what CPT has done is, and I think it's important, if you're in the medical world right now, to understand that CPT has this thing which is called Appendix S, which is basically just the appendices at the end is A, B, C, D. This is just S. So there's a lot of appendices. And although I don't like the categorization, and most people have some problems with it, the categorization of all AI tools in medicine by the United States government is either assistive, augmentative, or autonomous. I don't love those descriptions, but I'll tell you in general what they mean. Something is an assistive technology in medicine if it helps you do something that you could do yourself. So that scribe is assistive, because another person could certainly do it. You could certainly write everything down. Something that is augmentative is something that you couldn't easily do by yourself. And a nice example that I think of is an AI tool that actually calculates the biliary volume or liver transplants. It is true that a radiologist could try to segment, the smallest of all the bile ducts they see and calculate the biliary volume. But it would be really, really an unfortunate day for that radiologist if they were going to try to do that, because, there's a lot of sick people. We don't want to be doing all those things. And so that is augmentative, right? Another example of things that are augmentative are things that kind of calculate cardiac risks. A lot of things that Michael are going to show you are going to be augmentative. And something that is autonomous means it can happen independently. And the problem with CMS and some of the difficulties is what, in my opinion, at least, what is autonomous could actually be assistive or augmented. But autonomous just refers to the fact that it's being actually done completely autonomously. And you can imagine there's not a lot of things that happen that are truly autonomous, at least in the medical sector. Yes, in the Waymo, not so much in the medical sector. So this is how Banner's doing it, and I won't go too deep into it, but you need to ingest the Banner data, you need to store that Banner data and compute with that Banner data, and we're using a solution that's AWS and Databricks to do that. And when you're on a Cerner system, there's a lot of complexities in ingesting that data, but we're in the process of doing that, and hopefully we can use some of that data in Wellness Hub. So what does the Center of Excellence look like? There's one representation of what it could look like, but we want to be practical. So we want to save time and we want to save money. So if we're doing these two things, those are the two things that we can do. And what this really looks like is, and we actually now, thanks to some of the funding and thanks to some of the support, we've now kind of pulled together this team where we have department heads, IT, administrators, all kind of thinking together in a deployment committee. So in order for something to now make it into the UA and the Banner ecosystem, it can't just be something that's jerry-rigged and one person said, hey, this is really good, let's just do this. It has to actually go to a central committee. It has to get evaluated. And it has to be vetted, not just like vetted by IT, but also vetted by the experts. And I won't go through it, but kind of after something's been FDA cleared, kind of as a physician champion, it goes through the committee. Everyone, like I said, remember, someone's always watching, goes through their COI. We have a formal intake. We present over and over again. That, goes up the ladder. Leo's actually on that committee with me. And then we actually have a planned deployment. If something's not FDA cleared, it's a little bit different, right? But it's much the same. And what we really want to do is we want to take this patient who has a medical event, who will normally have, after that big medical event, will have all of his labs, imaging, monitor it, and that first event may be something like a presentation of a metastatic cancer. We want to move that back in the timeline so that we have what's called biomarker discovery. So, we have data, at the cellular level, at the tissue level, at the organ and human level, how that organism interacts with the other in the atmosphere. And, actually able to know and do that biomarker discovery before that patient actually has that event that's going to be the presentation of stage 4 disease. And that's proven. So these are some of the principles of the clinical Center of Excellence. We should call that Wellness Hub before we were Center of Excellence. It's a long story. We want to use best AI practices. We want to use the AI tools regardless of their source. And we have a patient ethical obligation to kind of own and steward that. So I'll end up here with a picture of the caviar from the beginning of the slide, right? We don't want to let the data go to waste, but we want to use it in the right way. And imaging, certainly in our neck of the world, will be AI based. And we want to make it the best test that we can. So I'll stop there. And I don't know if we have time for questions now or we can take them later. I don't know what your. You want to do some questions now? Happy to take some questions now while Leo kind of sets up his other computer. Sit up. Thoughts?
Back in December, when they had that ASU Business Health, they had the person from, it was Toronto, we talked about efficiency and how AI is helping get to that 80% efficiency a little bit quicker, I think was her presentation. Is there any risk to, when you get to that, you just stop and you don't go to that extra 20% to, does that make any sense?
The guy from Toronto's right here. He's right there. But when you get to the 80%, I mean, kind of in terms of like sensitivity or
acceptability, like
acceptability.
80%. I think she mentioned it like an art piece. An artist, when they get to 80%, most people get, wow, that looks finished. but to the artist, they know that.
Oh, okay, now I remember that, yes. I do
But,
remember that.
I always just started thinking about that on the drive home, and it kind of freaked me out a little bit because it does seem like, yes, we will get to efficiency faster, especially with the one person using it. But at the same time, are we just gonna accept mediocrity because AI, that's what standard is? Or are we setting the standards for AI really high?
I think that we're obligated in our world, we don't do anything autonomous. We really practically have zero autonomous AI. So everything has the same standards, and so you won't stop at anything that's 80%. Well, I'll give you a hard example. Let's say that we were to deploy a pulmonary nodule detector, right? And so it's kind of a good thing, the vendors will have one say and we'll have another say. If there are 5 pulmonary nodules that are detected, the radiologist is going to look at all 5 of them. They're never only going to look at 4 of them. So we're not going to be an 80% organization if we use a tool in that fashion. If we're going to deploy this AI scribe data, we're not going to do it for just 80% of the history and physical exam. We're going to do it. But I can see that in other scenarios that are non-medical for sure. And if we made a deal, right? Let's say that I'm truly just spitballing this because I have no idea. But if we were to make some type of plan where we had a deployment and we could get some type of interaction between Gatorade, Waymo, and ambulatory service line to actually, pick up patients who, are critically dehydrated or just bring hydration to different places strategically at 4:00 in the afternoon, under the 10, under the 202, at the intersection of the 60 and the 101. I can think of where it should go right now, right? Just from driving around the Phoenix. If we were to do that for 80% of the sites, I would be thrilled. That would be a huge victory. So in that scenario, 80% is a total win. It would be like, we'd probably save 50 lives every summer, maybe 50 lives every month of every. So in that percent, if we were to do something like that, and we were to strategically know where those people are because we had some type of data to show that that's where, we're going to be able to do AI for good, I would take 80% in a heartbeat. I'd take 60%, right? And so what? So we drive around a little bit, we drive around a little bit for the other 40%. Nothing gets delivered. Maybe we waste a little bit of money, of Jaguars tuning around. The number of Waymos is like 2% of all the cars. Right? Think of all the other cars that are there. At a minimum, they can pick up the traffic patterns and help, save $1,000 a day, $1,000 a minute on gas if people, being rerouted. So I guess the answer is it matters the scenario. In some places, 80% is totally not acceptable. In some cases, 80% would be awesome. I'm not sure how to get the other computer up, John.
So I've done a lot of reading about this and I've seen that people are talking about medical professionals, doctors, especially using AI tools to do differential diagnosis and things like that, because there's just too many possibilities for everything for a set of symptoms.
Sure.
And, I can do the same thing through WebMD or something like that.
ChatGPT.
Yeah.
Or the medical version of ChatGPT.
I could say, hey, if I exhibit these symptoms, what does it look like? And it's going to give me
It's going to give you your differential diagnosis. Yeah.
It's never going to pin it down, but it's just like in radiology, you can identify a nodule, but you're going to have a biopsy to really find out more about it. It's not going to be just the diagnosis. You're going to say, you observe this, but the doctor is going to have to take that information and do something with it in order to inform the patient.
Doctor's going to have to do something, but don't be surprised. So there's things called liquid biopsies and there's things called digital biopsies. So don't be shocked if, I don't know, Michael, you're going to talk about nodules at all?
Yeah.
Don't be shocked if, oh, don't be surprised if, there's another field, we didn't talk about radiomics at all, that, you can actually extract more, you can actually get more than the caviar. So the caviar there is a 12 by 7 millimeter spiculated nodule in the left upper lung, right? But, the deeper information is, obviously, if you have a surgical biopsy, you take it. You can actually do, a core biopsy, and, a little less invasive, but you can find out what it is. But don't be surprised if you can actually get closer to a tissue diagnosis directly from the data that's in that CT scan that you can't extract with the human eye. And that's getting more of the fish. That one was on the side that we can't get. It was one of the ones where I showed the life cycle of lung cancer. But a digital biopsy is not an unreasonable thing to think about. Just leave it at that. You don't need to show this.
I would also add to that, John, I think that we should, and that goes also to the 80% question. I think that we should kind of transcend the way that we think about AI in medical practice, incorporating agentic AI and incorporating structured, rigorous ontologies, which are formal representations of worldviews, which can provide a rigorous definition, which gives you 100% logical definition that is fully differentiated and specialized to a particular diagnosis, pinpoints it. And ontologies have existed for a long time before Palantir, but that's one of the core technologies that they use to kill people. But the point is, you don't just rely on a single LLM or an ensemble of LLMs to do the whole pathway of patient care or differential diagnosis. You can incorporate outside resources and things that don't have just an 80% accuracy rate or 90% accuracy rate, but much higher accuracy rates that are specifically optimized to answer specific questions. So within an agentic approach to your question, do I have disease X? You could have a portion that draws from the existing literature, from an existing relevant corpus of literature, and another portion that enacts a logical pathway and requests specific either laboratory tests or computational tests that are then enacted, and additional information is added dynamically to then pinpoint the differential and to narrow it further. So I think we shouldn't, LLMs are exciting and AI is exciting, but just because we have a hammer doesn't mean that it'll, everything is a nail. So we'll have to incorporate all of these technologies together, bring them together to become more precise.
That's kind of where I was going with my thought pattern. And the other thing too is that one of the other avenues that medical businesses are using is kind of funneling the doctors' thought processes and limiting or adjusting what it says, let's say, have you done X, Y, and Z, then you can do, or X and Y, then you can do Z. If you haven't done X and Y, you can't do Z, because of insurance. Because now insurance is guiding the process, and they're using AI for that portion of it. And I've seen it firsthand how that can kind of guide it. It's no longer where the doctor is able to use intuition and knowledge and experience, to go beyond what the guardrails that are established.
Yeah. All right. There's some good questions. I'm going to do Alana's first. Oh, there's more questions popping up. First of all, Alana, we have the same dog. Because I see in your little profile, your little version of my dog Kennedy. So I should put a big heart. So that, or a big smiley face. So because I miss my little doggy, I'm going to read your question first. So, do you want to go off mute and ask it, or do you want me to read it?
Oh, I can ask it. And yeah, they maybe they're siblings. Maybe they're long lost siblings,
Well, we know the audio works.
which is good. That's good. Audio works. Okay, I hope I'm not too loud.
No, you're fine. Go ahead. You can ask it in person. Maybe it might be better than me reading it all the way out.
Yeah, so I just was curious how the AI scribed notes are being checked for errors after meeting with the patient. If AI is not really capturing audio at 100%, things could be missed or transcribed incorrectly. And there's a show called The Pit that just did an episode on this. So I was kind of curious, like, what happens if an AI scribe says someone is like on methadone, for example, when really they're on metformin?
I hate when that happens, but
Right? Common error.
I mean, methadone would cure your diabetes if you took enough of it. So, 100% physician oversight. So that's going to tie, and the reason I read yours is I'm going to read the second question in a minute. So right now, Mr. Garcia's got a call from the methadone clinic and had to step out. So all of those things are being live checked and being managed by the physician wholly. And so that goes into some of the loss of the ROI. So the big ROI is the note is written. The problem is that these things that the physician would never make a mistake for will get messed up. And I would love to see the show. You said there's a show on it. What's it called? Because I want to watch said show.
It-
The Pit, like PIT?
Yeah, PITT. It's like a medical show where they're in an emergency room in Philadelphia, I believe.
It should
But
be
they're
Pit-
bringing up some pretty current issues like this AI scribe being used in an emergency situation or emergency room situation rather, and then it transcribes something incorrectly.
So I'm definitely going to see it. I assume it's Pittsburgh. It's got to be Pittsburgh if it's the Pit. So
Right? Yeah.
physician, in that case, physician 100% accountable for everything that's scribed.
Okay.
Simple. It's your medical error. It's your note. Relates the point here. The Banner physician clicks the button and that note goes into Cerner and it's just as if he or she typed it his or herself. So 100% accountability physician. But now I'm going to read the next question. And the next question goes like this. If there is an error related to diagnosis, who would be considered responsible? The AI company, the physician, or the insurance provider? There now is, and so I have no disclosures. I have no skin in the game for any company anymore, right? I'm out, totally clean. There is a company, I won't name the company, who does breast imaging and now has said, we will be accountable for any mistake. Put all of it, use our tools. We're now accountable. We're self-insured. You have a legal case from our thing, come to us. And that has completely changed the paradigm. Completely changed. And you can Google it, look it up. I don't want to name any companies and this is, state funded. I don't want to look like I'm supporting anyone. And I'm not going to say whether I support it or whether I don't. But it is a complete game changer when now a company has said, we've got enough skin in the game. We're in this. Breast imaging is specialized in so much as a lot of those training problems that you think about, like, remember I said the CT scan, they all have different slice thicknesses. They all have different signal to noise. They all have different contrast to noise. There's nuances between vendor A and vendor B. In digital mammography, a lot of those things go away. Yes, there are different sizes of breast. Yes, there are different things, but a lot of those things can become more standardized and they've gotten a lot farther along. And that's the first time that the company said, okay, we're going to be responsible for our own mistakes. So total game changer.
And I'll add to that recently there has been a couple of papers that came out. So for radiology, we've been using voice transcription for years. We didn't call it AI, but that's essentially what it is. So voice transcription introduces all sorts of errors that are completely incongruent with the rest of the report. And recently there have been a couple of publications that came out that actually use LLMs to proofread things for words that stand out. So you can have a secondary LLM proofreading your report and ensuring accuracy, or just pointing out to you things that are kind of suspicious. So that can actually be an additional force multiplier for you if you're looking at AI generated political notes.
For example, it will flag if if in the body of the report, you're talking about the left leg, but then somehow at the impression you say, distal right tibial fracture, it will actually make that thing red. Try to say, hey, look at me. Look at me. Maybe you got the wrong side. All right. I'm going to do one more. Try not to answer this. How are you going to, I think, mediate AI tool hallucination errors? So, great question. Everyone here knows what hallucination is. It's probably going to be covered in kind of more straightforward presentation. So we're going to mediate them the same way we do in non-medical things, which is we're going to look at them, we're going to evaluate them, and then we're going to just continue to retrain, continue to give, continue to follow up. So if we see more and more consistent hallucinations, we're going to try to flag them. We're going to try to make workarounds. If we can't find consistent ones, we're going to make lists and try to retrain, in the most strategic way that we can. But we know that that's going to happen. And we know that that's not going to be a frequent problem. It's not going to be. I will say that I've noticed that, at least in the large language model, I've noticed that a lot less over the last 5 or 6 years. There's no scientific. Just anecdotally, I've noticed that. That's not saying that it's not. I have noticed that. There's some more. I think in the interest of time, we should have Leo. I know he gives a great talk. And I'm sorry, his is better first and then mine second, but we've got his slides up. Dr. Leo Sheplev is a master programmer. He's a fantastic AI scientist. He actually worked all last night and then took an Uber here. And so that shows a level of commitment that is beyond ridiculous. He's, I'm not sure why he's not a full professor, probably because we haven't put him up for promotion, but he is an associate professor here. He's going to be an integral part of the Wellness Hub, and he's going to talk about best practices. So,
To stand up. All right. Okay. Thank you for the introduction. I just wanted to start with a brief kind of poll of the audience. Who is a physician here? Are there any MDs in the audience?
this little group is the medical students.
Medical students?
And
Okay.
there are some physicians online. I noticed some of the names.
Physicians online, excellent. Scientists, scientists, okay. Programmers? Couple of shout outs. What are you expecting from this talk? What would you like to learn?
I'd like you to stay awake.
Well, that's one thing. Hallucinations will be a part of this presentation. But anything else beyond that? Any specific point? Okay, so I have a better understanding of what our audience is. So this talk is less of me giving you prescriptive best practices for good clinical AI, and more sort of me ranting and us thinking together about what the future will hold. For best practices in clinical AI, there are all sorts of governance initiatives. CHAI is probably the most well-known CHAI. You could look it up on your own time, or you could take a look at a link that I'm providing that actually provides you CMEs if we had more MDs. We provide CME credits for completing some of the learning. So the question is, why ask radiologists? And basically, the vast majority of AI applications in current clinical practice that are FDA that are listed with FDA are in radiology. The second, and it's a large rift between the first and the second place, but the second is cardiovascular and then neurology and so on and so forth. And one of the reasons that underpins this is the ready availability of the data, the computational frameworks that have already been established, the computerization of our care, the back systems, and existing technologies and frameworks that enable ready use of the data, training on that data, integration of the electronic health record information into this unambiguous and objective data that can be then converted into trained AI algorithms. So that's why radiology is kind of ahead of the curve, and we are also ahead of the curve in terms of the things that people tell us. And I really love this image with predictions that we'll have self-driving cars in 2 years, in 2015. Last I heard, that is not really going very well for Tesla. That's my former colleague here in the middle, Geoffrey Hinton, from the University of Toronto, saying in 2016 that radiologists are kind of like the coyote, either dangling over an abyss, and we're done as a specialty, and we should stop training radiologists, and they'll be obsolete in 5 years. And then I have to update this slide every year. It's 2026. We're driving to work. So not much has changed for radiology in terms of our appointment with the implementation of AI. In the general clinical practice, and this is the QR code that brings you to the AMA learning resource and gives you CMEs if you're so inclined. The AI is used in a wide variety of settings and purposes. There's documentation of billing codes, medical charts. We've spoken about taking notes. There are instructions. There are all sorts of form filling, back office applications, things like that. And does anybody in here have any application that they have been using in healthcare? Or so that's the current state of affairs. In radiology, we have a series of applications, and they stem from semantic segmentation of images. So segmentation is basically identifying of the region of interest, and the term semantic segmentation is we're attributing a meaning to it. So we can, for example, select the skull or a specific anatomic structure and then use it in further subsequent calculations. So one of these image-based semantic segmentations, how it can be used, for example, can be used for planning of operative procedures and in localizing of the instruments within the patients. One recent example was where 12 people have had errors as a result of inappropriate AI-assisted segmentation based on CT imaging of the skull, where the surgeon was conducting transsphenoidal surgery, and based on the inappropriate segmentation, the instrument was registered in the incorrect location within the patient's skull, and essentially resulted in a couple of cases in strokes, hemorrhage, carotid artery was punctured, things like that. So that's segmentation and what happens when it goes wrong. You can also segment specific regions. For example, you can segment a nodule, and then you can perform radiomics analysis of those. Radiomics is basically when you take a number of computational features of the image, and it's like we select from thousands and thousands of different signatures of an image. So you can think about nodule heterogeneity, for example, nodule size, nodule attenuation, that's how dense it is, and use that to further predict risk scores, things like that. So that's additional layer upon semantic segmentation. And then you can incorporate all of this data with additional electronic health records data, genomics, laboratory and pathology information, photography, device and monitor data, to then bring that into a single framework through a series of steps that then result in the things that we have discussed earlier. clinical risk scores, diagnostic differentiation, prognosis, whether we can capture patients at risk earlier in their pathway of care, automated follow-up and prevention mechanisms. So that's kind of the ideal what we're going towards. Now, unfortunately, this can only come as a result of integration of a number of technologies, a number of disparate fields, a number of disparate vendors, understanding of common architectures, interplay between various players who may have different competing interests and may have a different understanding of what it takes to kind of reach this ideal, this holy grail of computational assisted patient care. And so I just wanted to highlight a few limitations and things that we're running against with the current wave of AI implementation in clinical practice. And one of the topics that I wanted to cover is patient privacy. And so one of the walls that we run against is HIPAA. If you're not familiar, there's a number of patient identifiers that must be removed from patient records prior to sharing that information for further research purposes and further reuse. So, for example, when your insurance sells your data to a third party, and they do that, they must remove certain things like, gender, date of birth, your address, the timestamps, and a number of other features. Now, unfortunately, that's all good and well, but unfortunately, with the emerging technologies that we currently possess, there is this paradox of de-identification. This is at the top, it's a paper available on arXiv. You can take a look at it if you wish. But basically, the idea is that you can use LLMs to re-identify certain features of the patient. And for things like sex, it's basically slam dunk 100% of the times, even if it was explicitly removed from the note. There are features that are identifying the patients within the notes without saying what the patient's gender is or referring to them by, pronouns or things like that. You can identify the zip code that the patient lives in, fairly reliable, age of the patient, fairly reliable. The accuracy for a number of these parameters rises to about 80%. You can unambiguously identify only 0.34% of people using this technology, but I just want you to think about that this is just notes. It's just text notes. Now, think about what happens when you connect that to imaging data and genomic data and visit information and very specific unique things that might have happened to you in your care history. What if you're a patient who, in your chart, it's written that you are, a top athlete at your local school, and then that top athlete has lymphoma, and then there's an X-ray, and then there's a CT, and the face was not removed from a CT, or the CT contains earrings. What happens then? How easy does it become to re-identify? So back in 2010s, maybe 2013-ish, there has been a lot of buzz in the news where an individual has identified, I believe, 5 out of 10 study participants, and one of the study participants in a genomic database, just with genome sequencing. That researcher has been able to pinpoint them to home address and came by to say hello. From genomic information, just the 4 base pairs. So that kind of tells you how effective this can be and how we must really think twice and thrice and 4 times about how we use this data, especially in the times of AI. One other thing that I'll mention here and that I'll mention again is AI is not unbiased. If anything, it brings out re-identification of patients and brings out the biases that are inherent. So just like Dr. Abiki was just talking about, can we have some information that is hidden within a scan that can help identify sick patients earlier? You also have information hidden in the scans that reliably identify patient race. I can't identify, the patient's race when I'm looking at their chest X-ray, but in this paper in the Lancet, it has been shown that AI can reliably identify patient race from X-rays. And you can bring this to the concerns regarding patient re-identification from the data that's now available to all these AI companies. But you also can bring this to bias in healthcare and think about how the composition of the training data impacts fairness in patient care. So that's one thing. As a funny aside, did anybody do a 23andMe test for? Yeah. Are you feeling happy about your data being available for resale?
I actually pulled it back, or at least I hope I
Congratulations.
made the request and canceled my subscription when I found out that they were not securing the data the way it's.
How are you feeling about OpenAI proposing that you upload all of your health information to them and ask them questions about it?
I don't mind it either.
On the flip side, Devin's fiance did 23andMe. We found out she was 25% Italian. Now it's going much better.
All right. So re-identification and patient privacy and concerns about fairness and taking advantage of you. That's one thing that we've discussed. The other thing is the clinical reality, the AI tool use literacy. I've compiled here some examples where, it was identified that sensitive information is basically being sent from well-known companies. Basically, information is being uploaded and sensitive information is just being freely given to entities like OpenAI. And prompts contain sensitive content. The documents used for RAG, retrieval augmented generation, can be harvested for sensitive content that relates to a specific company. So to counteract this, most institutions like Banner have AI tools that are behind. They're not the best AI tools, but they're basically kind of localized to the local installation, and they're covered. I mean, at Banner, there are versions of Copilot, and Copilot is basically white labeled ChatGPT. So it is what it is. But in the real life, if you think about a physician who has access to patient charts, and they're not necessarily always on secured machines, secured computers, or they might use an external device. Think about, for example, the Meta glasses that could potentially take snapshots of people's lives. And they have been taking snapshots because people in Africa have been complaining that they are exposed to intimate lives of people who are wearing Meta glasses and recording everything, including passwords and, intimate interactions. These things can percolate, and if you're not very thoughtful about how you use additional AI assistance, you can potentially break a lot of things. And breaking things seems to be a pervasive signature of the culture. We have just had the news that nearly the entirety of Claude source code has been fully and openly released a couple of days ago. As to their shares, but it's just a part of this world. It seems they just don't really care. Their response was, don't look at it. Okay. One example here was the brilliant idea that Recall in Windows 11 will take snapshots of everything that you do. They were reassuring us that if you're in private mode in your browser, they might take snapshots. But they'll take snapshots of everything that you do, and that'll be searchable because, that's what we want, right? I've always dreamt of it. I just didn't know about it. And so, shortly after this feature was released, a tool was created to extract all of your recall snapshots and mine them for information, which was great. They've said that they've patched it since, and it might not be a requirement in the new things, but the way Copilot has been jammed into everything, you turn around, you turn on your smart TV, and you don't recall adding a Copilot button, or your Xbox, which now has a Copilot app for some reason. I'm very skeptical that this will not be integrated, but you have to be very thoughtful about what tools you allow access to your valuable data. One other aspect that I'd like to switch to is we can talk about implementing good AI. We can optimize our detection. We can make things relevant to our clinical practice. We can make things, really impressive. But there's such a concept as alarm fatigue. Have anybody heard about this? Alarm fatigue? Yeah? Okay. What's alarm fatigue?
It's like crying wolf, isn't it?
Kinda, yeah.
And you get big, for instance, let's say you're hooked up to an IV and you bend your arm.
Yeah.
Lung goes up.
Yeah.
Or, your pulse rate,
Mhm.
goes up beyond the threshold.
Yeah.
For just a fraction of a second, lung goes up.
Yeah.
And it's like, there's nothing really wrong, but
Yeah.
the nursing staff and everything having to respond to check.
Yeah.
It takes away from patient care for other people.
Essentially, when everything is a signal, nothing is a signal. Basically, in radiology, so in ICU at the top there, intensive care unit alarms, how many do we need? This paper talked about 566 people die each year because of alarm overload. Everything beeps for no particular good reason. You cannot focus on things that are truly important, and as a result, people die just because you're distracted in the ICU by all of this information. Now, in the more clinical practice, there was this tricorder AI-assisted stethoscope that facilitated the diagnosis of heart failure. And basically, at first, there was a Lancet publication that was saying that, this AI-assisted stethoscope is great. It allows us to diagnose heart failure more. And there was a follow-up paper that said that, actually, you know what? 2/3 of that is misdiagnosis, and they're false positive. And that was in Britain, so I wonder what that did to their healthcare system. And it was on 200 or so clinics that covered 1.5 million patients or so. 12,000 patients were included in the analysis. So that's another oops. And as a result of that, silently, you might read the initial paper and say, I'll be a much better doctor with this AI-assisted stethoscope. I'll, diagnose heart failure like this. 70% of the practices in 12 months dropped using this AI-assisted stethoscope, which kind of brings us back to radiology. So in mammography, at the outset, we didn't call it AI, we called it CAD, computer-aided detection or computer-aided diagnosis tools. For mammography, you would have all of these annotations for basically every lump and every little focus of matter that is kind of suspicious to the algorithm. And so in those 10 signals that the CAD software showed to you, one of them might have been important. But because you have this alarm fatigue, what that translated to in practice is that people just flipped over the last page, which contained the CAD annotations as quickly as possible, and just kind of went on to the next mammography study. Now, since the 2010s, there has been utility proven as a result of the use of these CAD techniques and additional annotations. And you have to be very thoughtful in how you integrate these annotations in order for this to actually make a positive impact on patient care. So you could have all of these wonderful AI assistive tools, but if they're not thoughtfully integrated into your clinical practice, they could be useless. Did anybody watch Idiocracy? Okay, wonderful. 4 people are very happy in this room. The rest are, huh? What's Idiocracy? If you haven't watched it, watch it. It's a classic. It's great. It basically talks about what might happen to us in the future. And part of this is, the main character comes to this hospital here, St. God's Memorial Hospital, that tells you the idea of how intelligent the future is. And he comes to the to the lobby, basically comes to see the receptionist, and the receptionist is basically pressing a number of buttons based on what he says. I'm like confused, or I have a hurting knee, things like that. So AI has an important impact on us as humans, and a lot of people are starting to remove AI from learning environments and going back to written materials, notebooks, paper, pen, and essentially the reason is that it's kind of making us dumber. I mean, how many times have you seen not an AI generated voice, but a human come to you? You're watching a YouTube video and they're like, it's not X, it's Y. It's not just blah, blah, blah. This contrastive superimposition that, AI really loves in writing their scripts. They're just generating the script, hitting the button, reading it to you, probably putting in the prompt, what would make people, really watch my video. And that kind of drives our environment. I think certain skills atrophy as a result. So this paper in the Lancet again shows that as a result of AI use, there is endoscopist dyskilling. And this is a study done in Poland on a very large number of patients. I think also, I don't want to lie, but I think it's on the order of a couple of hundred endoscopists that were enrolled in this. And basically what this showed is a drop in they did an assessment before the incorporation of AI-assisted endoscopes and after the incorporation of AI-assisted endoscopes. And they looked at the accuracy of detection of polyps and lesions that then require follow-up. Basically, how good you are in seeing these possibly pathologic lesions as a result of endoscope use on the camera. So you put the endoscope up the rear end, and on the camera you see things, and this might be a polyp, this might be cancer. And it turns out that after the 3-month period of use of AI-assisted endoscopes, what's your guess? What happened? Did they become better endoscopists? Did they become better doctors?
They got worse.
They're worse. You think so? After reading the title? How much worse were they, do you think? What are the bets? Who goes for 10%? Who goes for 20%? Who goes for 30%? Okay, the 20% had it. So it's basically a 20% drop in the accuracy of detection of polyps, of cancers. So imagine, we have this system of dating. Endoscopist just says, we'll do it raw, we'll do it live. And they put the endoscope in, I'm a doctor too. And they look at your colon, and then lo and behold, 20% lower detection rate. So you have to pray that if AI is incorporated, they keep using it, or occasionally, maybe they in some cases use it way back. So there's an interplay between AI and us as physicians. So going back to that question is, who's responsible? We're always responsible. We're always the most responsible person, and we're responsible for our work. So we have to be aware of this interplay. One final point here in general considerations that I wanted to touch upon is the practical aspects of deployment. So there are tertiary centers, primary care settings. And as we're in the hospitals, it's really easy to forget that there are physicians out there on the front lines, family docs, somewhere in a rural place where you might not have access to computational resources. You might not have access to IT teams and things like that. So In the tertiary centers, there's deployment of software within institutional computational environments. There are IT teams, security policies, and limitations on the use of AI and software in general, so that you can't just Dropbox the entire electronic health record of your institution or clinic. And there are agreements with well-defined data sharing parameters. And this is really key. People are generally not aware of how much the data is worth, and it's basically worth it. And agreements are negotiated between these virtual entities and individual physicians and patients and providers, where data is obtained for basically nothing. But it is the lifeblood of the current technologies. And basically, without that data, these companies but because these primary settings might not be aware of this, negotiations that do happen are disadvantageous to them, and they're being taken advantage of. Primary settings might also be, their only choice might also be to partner with larger companies that have computational infrastructure, and they might have limited stewardship of data as a result. So basically, this is kind of what this looks like in practice. On the left-hand side, institutional solutions, that's your typical server room. That's really noisy and probably cooled with several jury blowers and somebody's nightmare to wire. Then on the right-hand side is you basically give somebody money, a lot of money every month for a subscription to run things on their infrastructure. Then they might go off and do their own thing. However, a cardinal sin of the current AI technologies and the current AI development, I think, is the lack of realization that you don't always have to go for large and larger and larger and larger language models. Your clinical solution might actually be somewhere more local. So we've discussed how there might be purpose-built solutions that can be incorporated into a good enough reasoning model that might be able to address a specific question. So you don't have to train a large language model to be great at answering, if this nodule is malignant. You can build a computational model that can compute this using radiomic parameters, using additional data. You can incorporate pathology information and get results that are outstanding with a limited fraction of the power that's needed to replicate a human or develop general artificial intelligence. So there are solutions that are good enough. Thanks to the development of computational architectures that have shared memory. So, there's this AI Max 395, there's the M5 on the Apple side. You have the ability to have pooled memory resources and deploy locally on a single machine that runs fairly quietly these large language models. And for example, have local deployments. Here, XNG is a AI-assisted search engine, so you don't have to send your queries to Google and inform them of your every thought. You can have locally based retrieval that is not identifiable. Things like Ollama and LM Studio allow you to deploy openly available, publicly available large language models. And all these resources are available. It's fairly straightforward to set them up and point them to a specific resource, be it a prompt, much like what you can get with OpenAI, or be it within a development studio integrated development environment. So,
Can I ask a question about that?
yeah, sure.
So I've been thinking about this a lot. And we were debating yesterday. How practical is it for, let's say, a large private practice? We'll say non-academic, or this new term I'm trying to promulgate, the private-demic. To make their own solutions in the hospital, use them in the hospital, have them be not regulated by the FDA because it's a practice of medicine, and each go on their merry way with their own training sets and their own tools, and still keep the same way that we do our practice, that we collect our money, and that we kind of go on and we increase efficiency quietly, locally.
Yeah, no, it's very reasonable. So I think right now at 128 gigabytes of memory, which you can get a machine for. I bought one for 2,300 before round prices really went up. You can get one for 3K right now off Amazon. You can build a system that can support OpenAI 3.5, ChatGPT 3.5 level. So 70 billion parameter models easily and run them at about 80 tokens per second. So that's pretty fast generation of data. So that's really accessible. You can get a graphics card that has 94 gigabytes of memory procuring for $8,000. So it's really within the realms of the means of just the general people who are buying laptops, you know. So computationally you can have it, but I think that the bigger question is we have to have a collaborative, a society of physicians who are willing to share open source information and frameworks, and then work together, maybe through entities like ACR, you know, work together to be able to share these algorithms and these frameworks to then build something bigger together.
So the hardest part's kind of the self-governance.
I think it's the self-governance and the ability to share, and it might not fly for everybody because you turn around and somebody informs you that they built this wonderful app using vibe coding that does a to-do list, and you know they'd like to now have an initial public offering for $2 billion. So you know that's the issue right now. Once we understand that it ain't that special, and that we probably should collaborate for the good of the science and the patient care. Once we get over ourselves, we can develop governance bodies and collaboratives that could share our expertise.
Can you do something in the neighborhood of having menus of optimized prompts?
Mhm.
You know,
Yeah.
and you just can choose and maybe fill in a
Yeah.
couple of variables and.
Yeah, that's the idea. Basically, like it would be something like this. So let's say we're doing a nodule detection algorithm. There's something that's already pre-trained on publicly available data, and there's a number of entities that have that. There are things on Kaggle. There's the cancer imaging archive. You're able to have genomic and imaging information. You can pre-train something, but then you have a pathway that you follow where if you'd like to deploy this locally, here's how you retrain something on your patient data. Here's how many patients that you need. And here's a dashboard that allows you to monitor the performance of this. So that's kind of the idea of this collaborative. The collaborative would create prototype, archetype implementations, and then individual practices would pull them down and incorporate them in their own work. So that's kind of what's envisioned. But I think that this is what might take this AI craze with the way that we're going now. The initial position is that, oh, these models are so large that the only way that you can run them is by paying somebody rental fee for servers. But you know, there's turbo.
Maybe the House of Radiology can't afford it.
But there are technologies that are coming constantly. A couple of days ago, TurboQuant decreases the size of your context window in terms of the implication on RAM. So basically, you're talking about like all the conversation that you've had before, and the environment that the LLM uses to infer the second steps or infer a specific decision about the patient decreases the usage of memory by 4. You know, quantization of models significantly decreases the requirement for the computation capacity and the cost, with only minimal decreases in accuracy. Combine that with purpose-built algorithms and throw that into an ontology, some kind of a formal guide rails, logic-based guide rails, and you have something that can be very powerful at a fraction of the cost. So you don't need to pay Sam Altman to rent his servers. What you could do is have an efficient solution that runs locally. Okay, we've gone somewhere. Right.
That's exactly where I wanted to go.
Yeah.
That's where we're going to go.
Yeah. So I'll just run over a couple of additional concepts for us to think about, because that's why we came in here, to just kind of think about a few concepts. That was one concept that I wanted to cover, and thank you, Dr. Rybicki, for covering it. The other thing is monitoring. So unless you observe something, it might as well not exist. So if you're not observing the performance of a model, you're not aware if it is well implemented. Think back about the tricoder example that I mentioned to you. Turned out that 70% of the people dropped it, and it had an error rate, a false positive rate of 60 or 70% or so. Basically, this is a quote from one of the vendors that we talked about an algorithm that it actually rarely or almost never happens that a nodule not detected by our algorithm is picked up by a doctor, but we do not track this. If you do not track this, how do you know? So in their mind, it doesn't happen, but we don't observe it, but it's not there, okay? And the thing is that it falls upon us to carry out this monitoring, and it's challenging. One of the challenges is that these probably are all the phrases for me to say that it's pneumonia, but I don't want to say it's pneumonia because that's just too pedestrian. So I'd say, GR space opacities might have been keeping with an infectious inflammatory process. So why do I have the aversion to say it's pneumonia? I don't know, and I'm not the only one, but there are a number of ways to say the same thing. And the thing is that it makes it very tough to monitor. And so one of the ways to monitor this is using standardized terminologies. So in radiology, we have RADLEX. In general medicine, we have SNOMED terms. But basically, these are our agreement that pneumonia is pneumonia is pneumonia. And whatever is, infectious inflammatory processes with patchy blah, 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 that's going to be mapped to pneumonia. And we're going to be using the term for pneumonia to be tallying false positive and false negative things, scores. And also, once we establish that, we can build dashboards around these concepts, and we also can provide the logical definitions that I talked about. So if we say that pneumonia is, just for the sake of this discussion, pneumonia is patchy opacities on an X-ray. We can build an algorithm that gives us patchy opacities on the X-ray, extracts that from the X-ray. We can also then, say it's patchy opacities on the X-ray, but also the white blood count has to be high. And also the patient has to have a fever, let's say. Okay. So that's our definition of pneumonia. Now you've introduced 3 parameters that you can directly measure. And once you have those unambiguously measured and plugged into your ontology, which is the formal worldview, where you say pneumonia is if you have patchy or space opacities and elevated temperature and elevated WBC, then you can infer that formally, infer that confidently, and use that both for benchmarking and for further prospective diagnosis. Bias we've spoken about, and we've talked about this, and the bias and the fact that you need to retrain all of these algorithms to local populations, and in some places like Phoenix, where we have people come here in the winter and then leave in the summer. Our populations might drastically change in their composition, and they might not be the same in the winter and the summer even. So we have to keep all of this in mind. Change management, there was an example in my previous live in Toronto where we integrated this opportunistic screening tool that detected osteopenia, also developed in Toronto. And the emergency department just went nuts on us because opportunistically detecting somebody with osteopenia and recommending DEXA scans for them is not their idea of a good time, because for probably 50% of elderly patients entering the emergency department, they probably came out with a recommendation that they have a DEXA scan at the end of their visit. So you can imagine what they did to turnaround times for patients and things like that. So we turned it off for the emergency department. Oncologists also said they don't want to know about their patient dying from cancer, potentially having brittle bones. But the basic idea is great because there's much increased mortality associated with undiagnosed osteopenia, and the intervention is really easy, and the diagnosis is really easy. So change management, incorporation of AI tools into the clinical practice requires looking at all stakeholders. Cost, I think Dr. Abicki has covered it, but the current model has been that all these companies come in and they have either a subscription fee or a fee per scan. And basically what it comes out to is, you know, you pay that company $5, you pay another company $5, but you are paid, you know, $50 per scan. So by the time that you paid
$15 per scan.
15 bucks, yeah. Our radiology department chief knows better. So by the time you've paid everyone, you know, you might as well start paying for the privilege of being able to read these scans that are AI assisted. So that's not a viable solution, and I think Dr. Abicki has talked about it, and he's doing things at the ACR to kind of support a more rational cost optimization. Now, opportunities, what this allows us is, we've spoken about additional interventions to prevent errors. We could have additional interventions to stop losing people to follow-up. We could have end-to-end AI-based programs, meaning that you have back office roles filled by AI-assisted agents. You have reminders that are dispatched to patients with positive, potentially significant findings. You have less of a ball dropped in the middle of patient care. So there's a scan, there was an addendum to the scan, somebody found a suspicious nodule that needs follow-up in 12 months. The patient was never aware, the physicians who ordered this in the ED weren't aware. It came to the patient's primary care provider and it went into a pile and nobody was aware. In the meantime, the patient develops cancer. So these end-to-end AI-based tools and end-to-end AI programs could potentially be a promising solution. And there are also creative ways to use this with force multiplication on some of the projects that I think are not as relevant to this talk. So I hope that I've given you some concerns and thoughts to think about the practical implementation of AI in the clinical settings. Things to chew on and things to try, perhaps local LLMs, smaller models, things like Olema and LM Studio, things like that you could try if you have any spare time. You know, being thoughtful, knowing the interplay between people and algorithms, and knowing the value of the data, and think about how we can build a collaborative together that puts the follow-up and benchmarking and quality control of these algorithms into the hands of the physicians to ensure appropriate care for patients. These are the major thoughts of that I'd like to leave you with. I think I'm at time. Somehow I managed to drag it into 45 minutes. So I guess I'll skip the questions and disappear or something, or Victor, what do you think? Take a couple questions again. What questions do we have? Is there moderation or? Can we see the questions? Yeah. Can I see them here?
Your pocket break here, unfortunately.
Okay, so I'll need to.
Need
Okay.
Nothing yet.
Oh, please.
Here we go.
Have you had much success with doing transfer learning on specialized radiology models? We've never seriously implemented anything. I think that so far we've been discussing, we've just been discussing the use of these kind of commercial solutions and things that kind of happen in the tertiary setting and not in the research setting. We are going to be more heavily invested in research, and we are using these models for segmentation. So my hope is that we will be doing much more of that. So there will be re-optimization of segmentation models for specific body parts. And I think it was when I was in Ottawa, 2018,
No, yeah,
2018 or 2019, shown at RSNA, I presented this this work where we showed acceleration of segmentation with models that are continuously improved based on the segmentations that are already pre-generated. So with continuous additional examples of semantic segmentation on imaging data sets, we were able to improve the performance of these segmentation models. But no, so far we're only using commercial solutions for liability purposes. But once we get research around that, we'll be doing much more. Any other questions?
More coming in.
Oh,
in the device manufacturing, we do use some of these tools. So we do it. It's segmentation, acceleration of device manufacturing, which we're starting. That was done 50 patients, so.
the person typing, I guess, abandoned, or it's a big thought.
Big question, possible.
It's Sandy Beckett. Your mom is typing. Yeah.
I can just ask you, in the work with AI models and the need to retrain and to make sure that we are addressing all the specifics that need to be there, how do you suggest training new physicians, new providers on the fact that AI is a tool, that the models are there to help us be able to identify things more quickly, maybe more comprehensively, but also to know that the true critical thinking and appraisal of the evidence involved really needs to fall back on that provider, and that we can't 100% rely on AI models, that we need to really make sure that that human factor of critical process is really important. But I'd like to know how you are approaching that with residents, with new doctors, with new providers.
Yeah, I talk. So in residency, you know, there are various learning styles, and I think I personally found the most successful learning styles are those that are not mediated by AI tools, but those who have open books or case examples, things that are kind of at the intersection of traditional learning, but kind of a bit more facilitated learning with direction towards the errors that they made. I think in teaching, AI can be helpful in creating the resources for you to look at based on your weaknesses and guide your learning. However, I'm not a part of the AI learning wave. We have a whole wave here. Individuals who can chime in. I would like to go back a little bit to the clinical part of the question. And so in the clinical part of the question is, I personally prefer models that expose the data that went into the decision. So rather than having a black box, we have the annotations and the basic raw data that allows us to understand what the black box means. For example, between two vendors, one which shows nodules as kind of within a space among other nodules, what we call NIP, maximum intensity projection images, that allow us to, as radiologists, to have an overview of the whole image and see what the computer has annotated. Gives me a secondary way to recheck the work of AI very quickly and to scroll through all of the images with the annotated nodules and see if I can identify any additional nodules. So between that solution that provides us that information, where I can double check the work of AI, and the solution that just gives us a list of nodules within a patient's lungs and does not give us additional secondary information, just gives us a bunch of annotations without any easier way to recheck the work. I would prefer the former. I'm a little bit old fashioned, so we've spoken about all this AI and clinical practice and application. I personally feel that AI has an augmentative role for my practice, right? Or I'd like it to have an augmentative role for my practice. So if we can accelerate, prioritize patients for those that are acute to be seen faster, that's great. If things can be measured for me, but I can double check those measurements, the tedious parts of the process are taken care of, that's great. However, solutions that completely take over, like we've seen with the endoscopist study, that's a no-go for me. So I think you have to lean heavier on the augmentative part and be very deliberative, very deliberate about how you integrate the results of AI into what it is that you're actually trying to do. So so we're not replaced, but augmented. And our thinking is still a part of the process. And we force ourselves to recheck that work by the virtue of the clinical process that takes place. Our medical students, do you want to chime in as to, have you found it, did it make you dumber? There's a nod for dumber. Is there any positive way that you think that you can use? I mean, I've used it to compile learning resources and give me examples, and for coding, it's great. It gives you some examples and goes through things step by step. But is there positive that you can get out? Anybody?
I love it. It is my personal tutor that I can ask the dumbest questions to. Like, you know, we're having a seminar with Dr. Bicky, and he'll be explaining something like, oh, these are photons, they're doing this. And then I secretly remember that I just don't know what a photon is. And then I go home and I use AI, and then it points me to all of its links too. And then I go into that and I can read from there without having to share, like I just did with everyone, that I'm not very sure on what a photon is. And it's made a really big difference, to be honest, in how I study before things too. So I see a case, I'm on interventional radiology elective right now. And so I see a case that's coming up in the afternoon. I put it into AI and I say, use me on every single part of the anatomy and physiology on it. And so then when the attending does that while I'm in the case, I get at least 2/3 right, which is much better than what I would have gotten.
So directs your.
Yeah, definitely.
But you do the learning, but it kind of sits in directing you. So
Definitely.
but hey, there's nothing wrong about forgetting what a photon is, because I did a little, as part of my PhD, I did a little part where I studied at Cambridge for a term. Welcome to those campus, whatever. And I went to this museum with Newton's belongings and his notebook and things like that. And the guy, the book is open, and every time he writes parabola, he kind of stops writing midway, crosses it out, and writes hyperbola or something like this, parabolic, hyperbolic. So the notebook was open to these pages where he was kind of consistently forgetting what he was actually, fidgeting between the two. Yeah, and I think we all have those cases where we kind of look up anatomy and things that we haven't, looked at, and various segments of various structures and classification systems and things like that. Any other examples? I think, was there something that you wanted to share about how you use AI, or? Yeah. Good. Anybody else?
Like, I use it a lot when I'm doing practice questions. And so if I get a question wrong, I'll basically copy and paste the whole question into like ChatGPT. And then I'll ask it to give me a 1-line script where it's kind of like this thing plus this thing equals this diagnosis. And so I feel like it helps to like condense that in my mind. And that way I can just review those short little scripts like periodically to better prepare for my exam.
Do you recheck for those brief things that?
I mean, I recheck it with a different.
I don't know, like
Reality.
yeah, like.
I mean, like, I can tell it's generally correct. I mean, I check it with the answer explanation too, like if I'm using UWorld, for example. But yeah, it's probably good to recheck it.
Any others? We had two more hands.
I was gonna say something similar to that with practice questions. Something I'll do if I miss a question, and all these question banks we have are really good. They're like gold standard for studying for boards and things like that. But often it's obviously static. Say I chose option E and it was option B. Option E has like one sentence and I can't, without going through my own textbooks or a Google search or something, I might not be able to reconcile what I was thinking with why that was wrong and how to bridge the gap between that and option B. And there are different like automated like guiding learning on Gemini or like giving a prompt on ChatGPT, whatever it is, to help guide from where you were, why you got it wrong, and how to bridge the gap between that and option B. And they can do it instead of giving you like paragraphs at a time where you kind of get lost, where it just asks you like a question and you can just like point by point get there to like really nail down that concept.
Yeah, so again, it directs your learning. Any sage words from our programmer?
I use it for X and Y machine. Since I think, it seems like 2,000 topics that are for step 2. I said, give me those 2,000 topics and in X then Y. So it's really pared down what I need to study to 30 to 90 pages instead of, I don't know, 50,000. And it lets me double check to see, is that actually correct?
You know what's funny? My wife's brother is is studying for dentistry, and he asked ChatGPT most likely questions for this exam for this section, and it generated those questions.
Yeah.
And then when he went into the exam, 7 out of the 10 questions were basically that, just kind of like slightly restated. So it must have been the professor. On the other hand. Yeah, anyway, no suggestions, just a thought. Anyway, so is that all?
Yeah, and we got enough time to do a 5-minute break. I definitely need to use the restroom. So when you get back, we'll have Brianna and Dr.
Get me to the bed so we can work it.
Have to.
Okay, I'm gonna go ahead and get started. So Beyond the Buzz, AI and rural health. So imagine this, you're a primary care physician in a rural environment in a rural healthcare clinic. It's the end of the day and you've seen 18 to 20 primary care complex patients. The internet's been in and out. The EHR has been kind of glitchy. You're the only healthcare provider for miles, and you have minimal support because it is difficult to hire. You've seen your last patient, but you haven't completed or signed much of your charting. Your MA has messages about missing medications or lab work needed. The scheduler has multiple patients on hold due to schedule. It seems very overwhelming, right? You are here because you want to make a difference and you want to help the community. You'll likely spend the next hour charting or documenting just to make it to the last half of your child's soccer game. And then you will still complete more charting at the end of the night or respond to patient messages, send prescriptions, and review results. This isn't necessarily a hypothetical. In rural healthcare environments, we ask a lot of the clinicians or the people that work there. Documentation has quietly become one of the biggest burdens. And this is a problem we set out to solve with clinical applications and AI. I'm Brianna. I have been leading the clinical applications in informatics at a large FQHC for the past 5 years. In this role, I've been trying to help our clinicians and support staff have efficient workflows so that the patient can have the best experience. I've spent the last year or so, a little bit longer now, working on implementing not only AI tools, but the governance and policies required to ensure safety. So AI as a solution in rural healthcare looks differently than in larger hospital systems. More of the focus is on documentation support, operations, business office, and clinical decision support. Many rural areas are lucky to have one primary care provider and the ability to do telemedicine. And even with telemedicine, not all patients are able to get effective treatment through that video visit. Advanced AI applications are not always practical in these situations. And instead, we want to support our providers in the ways that make sense. We want to augment the processes and reduce the documentation burden of the clinician and the supporting staff. Things like scribing tools can help with charting, AI call centers that can schedule appointments and have little to no hold times, revenue cycle management tools to increase the revenue, prior authorization or claims and denial submission support, and clinical decision support to reduce the cognitive burden and allow clinicians to focus on their connection with the patient. So I was working these issues are not necessarily new. The documentation burden has been around for a while. However, they seem to be getting worse. Creating retention and patient satisfaction problems leading to healthcare deserts in these rural areas. We had facilitated multiple, I was recently working for an FQHC and we had facilitated multiple quality improvement projects, but saw that AI was an opportunity to get clinicians excited and make a big impact in their administrative tasks, and did not necessarily know where to start. So we were able to partner with Health AI Partnership. So like I said, I worked for a large FQHC, North Country Healthcare. We had 13 clinic sites in the rural areas of northern Arizona and 2 mobile units. We saw about 55,000 unique patients yearly, and had about 80 to 100 providers in family medicine, pediatrics, OBGYN, dental, physical therapy, behavioral health, and clinical pharmacy. Our clinicians were MDs or nurse practitioners, PAs. And then we partnered with Health AI Partnerships to understand AI better and how to implement it across the organization. During this time, we had some challenges. We were under-resourced, financially specifically, but also our staff was under-resourced. We had small teams. We had we have broadband access challenges. So some of our sites in the more rural areas have interesting internet connection issues. We were also functioning on a legacy EHR. Some of our clinicians described it as a dinosaur held together with Band-Aids. And then we were also without a CIO or some of that executive leadership to guide us. As we were searching for solutions and funding, we came across this partner, Health AI Partnership, and their whole goal is to help healthcare organizations adopt AI in an ethical way. So our partnership with Health AIP, well, we had a cohort of other FQHCs that we could connect with, ask questions. We were all on different EHR systems. And so it was really just about implementing AI and what are you doing to make this easier. We had mentor sites, so like hospital systems that were maybe a little more experienced in implementing AI tools. And then we also had a network of experts in different industries like compliance, ethics, inclusion. The partnership also provided us with resources such as a vendor survey, which included things like best practices, ethical considerations, data privacy and security. And so we moved forward with the pilot project. The pilot project problem is that our clinicians, I think earlier it was said that you need a very specific problem for these AI. So we chose to focus on our clinicians spending too much time on administrative tasks. We had tried creating documentation templates to streamline charting, and that worked well for some things, like collecting structured data or quality data, but it wasn't necessarily an efficient process for our providers. And other problems were considered, but ultimately we did implement an AI scribing tool to focus on reducing the documentation burden. And we thought this would provide the most value to our organization. So like I said, we implemented an ambient AI scribing tool that could capture the clinician and patient interaction and provide the required documentation for the patient note. We were fortunate to be able to pilot multiple AI scribing and then make a selection based on the user preference. Our team was made up of the quality DCMO, Dr. Jennifer Cortez. She was going to make it today. She's our quality and population health DCMO, as well as myself, our data analyst, and our HIT project manager. We also had 8 clinicians at one of our rural sites in Kingman who had various levels of excitement or hesitancy. And then the whole goal of this was to reduce burden and clinical charting time. So we had a meeting where we used the provider mini survey. We looked at our Press Ganey patient satisfaction scores, and we measured the time to close charts. So during the implementation, there were a few things that were different than we had expected. One was our vendor selection. So we had the ability to pilot a few different tools. So we had an end user preference. We also had the cost and the financial position of North Country. So what was realistic to spend on these AI tools? We wanted to ensure that our tool was secure, like the data privacy and security, and that we didn't want to sacrifice any of that. And then most of the vendors had different pricing strategies and the contracting. We also, being on a legacy EHR, had to changed the workflow a little bit. So instead of the AI tool being integrated into the EHR, it was a copy and paste model, which we recognized was not the best, but we were going to transition EHRs and thought that this would do well for now, especially with the cost of building an integration. Learning and adoption, we had a lot of hesitancy in adopting AI tools. We also had a lot of excitement around the tool and AI in general, but getting the organization to standardize the use and either adopt it or provide options for adopting the tool. Christine. We also had a challenge with executive buy-in. Our executive team was very concerned about bottom line, which that's what they're there to do. And they really wanted to see how many more patients our clinicians could see with the use of the AI tool. And we didn't want the stigma around that to interfere with using the tool. Some of the results, we did improve the mini-Z scores, showing less burnout. So we measured before they used the tool and then after a few months of them using the different tool. And they were showing less burnout. We also had a little in-house survey where they could provide comments. And one of the clinicians said that she was very hesitant, but she ended up being a champion in trying to get her coworkers to use the tool. Our patient satisfaction survey came back very positive. Specifically, we had a Press Ganey question that said, my provider spent more time with me, and that got a higher rating during this time at that clinic. And then time to close charts was actually pretty neutral, but we think that was because of the workflow we had to implement, the copy and paste workflow instead of being integrated into. One thing that was really exciting and I think a little bit unexpected is 100% of our patients with informed consent agreed for their clinician to use the AI scribing tool. And this was, again, in a rural setting where not everyone's very comfortable with technology. So we thought that was really exciting and promising for moving forward. So as we were doing all of this, we had to establish the governance. We didn't have a strong data and security policy or AI governance, obviously, or data governance at the organization. So as we went through this project, we got to establish and develop that. We focused on we were able to create data privacy standards for when we are looking to partner with vendors, what we're willing to accept and what we need to kind of redline or review. We were able to understand how vendors check the model, or we set expectations for how vendors check the model for accuracy and bias. Is the vendor doing that, or is that something we as an organization are responsible for? And if we are responsible for it, do we have the capacity? And then we were able to ensure the providers understand that they have a role in this as well. They need to check the AI scribing output for like hallucinations or anything weird. And there was a feedback mechanism with one of the tools. Overall, we were able to establish an AI governance committee, and that committee was clinicians, IT, and operations, and risk and compliance to review all the software requests, agree on a strategy and organizational goals, and then provide training to the organization. We also developed policies and procedures. So we had an AI use policy that clearly spelled out how our, not only clinicians, but support staff could interact with AI. We had a software adoption policy and procedure. So that was any technology that was being requested for use would go through this process just to ensure that if there was AI, we were able to look at that. We also developed patient-informed consent, both written and a process for the clinician getting that consent at the time of the visit and charting that so that it's captured there as well. We had training about how to interact with AI tools. So what you can put into the tool and what you cannot, and if repercussions for if you were doing something that we didn't feel comfortable, like HIPAA or PII, we didn't want anyone to take that information into the AI. And we also had vendor surveys. So that helped us understand the data and security policies we needed to capture, how they monitor for bias or how we would need to do that. And how they would protect our organization and most importantly, our patients. This is just an example of the do's and don'ts we had on our SharePoint, just to make sure that people had a reminder, I guess. I'm not going to read it. So where AI in healthcare is going now, I guess more on the operational side. Ambient scribing is standard. A lot of EHRs have integrations or it's part of their system. AI call centers and scheduling, I think, is something we were really excited about. And then there's coding and documentation support, eligibility and prior authorizations, or claims management or denials management. And then moving forward with AI, I think we need to be very excited, but we also have to be cautious about some over-reliance on AI, which goes back to checking the output and making sure it makes sense, or checking the sources. Bias in models, how do we mitigate those? Data security, and then the lag in regulatory. In AI and rural healthcare, I think one of the biggest takeaways from that project was to share the resources, help the different FQHCs across the country were able to help each other out and have stronger material to implement AI at the organization. I think there's also some challenges with affordability. A lot of FQHCs or safety net centers don't necessarily have the resources, the teams, or the ability to implement AI. And how is that going to impact our patients? And then understanding that the AI is to augment the processes. We are not trying to replace any humans. We very much need the humans, but we just want to try to make the burden of documentation or some of those administrative tasks less, and educate our patients. If they don't understand it, we can't necessarily ethically. Okay, I have a very short presentation. But are there any questions?
Please put your question in the chat.
What were some of the reasons given for the hesitation in vendor adoption of AI tools? Like what would they?
Remember, clinicians just really didn't trust the AI. They didn't trust that their patients' information would be safe, or that it would be a technology that would help their processes. I think the training and the adoption process really kind of invaded that. So if they don't get enough training or resources or information about the tool and they don't quite know how to use it, it could add burden instead of help with the burden. So there was a lot of hesitation with that. And then, like I said, just keeping their patient information.
It's all being direct, pragmatic. In this environment, it's a lot of different resources. How do you pay for it?
That was tricky. Getting our
That's why I asked.
executive.
That's why I asked an easy question.
Yeah,
How
it
do
was.
you feel about it? How do you pay for it?
So in our situation, like I said, we piloted a few different tools. We had a favorite tool and we're not able to move forward with it because of the cost. At the end of the day, I think we chose the one that was least expensive.
If you go with Leo's idea, we just make you the tool. And it's free.
I mean,
You could talk
I
to
think-
Dr. Cortez about that for sure, because I think.
Yeah, Dr.
That's,
Cortez
but that's the whole
that.
wellness of it. We just make you the
Right, and I think that's probably one of the biggest takeaways is we need those resources and connections so that it is affordable, or there are,
This is all in Arizona, right?
Going in Arizona.
All in Arizona. So that's what Leo's talking about. Like, you know, he's close to home by now. You know, maybe that's something that we do. We just make this tool. And maybe it's the 80% thing. It's 80% starts out as 80% as good as your top choice and 90% as good as your actual choice. But then you start using it. I mean, that's a great project. It's pretty straightforward.
collective.
All of it. You've got your narrow people and it's extremely well contained, like in all of those things, like what's a good problem for AI? That's a great problem. Now you have your homegrown scribe tool. You can own it. You know,
Yeah,
a colleague to my left can fund it. It's already funded, right? It's already funded. It's already funded. And now you've got a great thing that you can do. And you can just start using it. You can even use both of them for a little while. Because you've got to continuously pay for whatever you bought. The subscription service, all you can eat. Is it all you can eat subscription or is it pay per play?
we actually discussed both of those options. We were in North Country, filed for bankruptcy. And so the finances were pretty tight. And we were looking for creative ways to make this work. With all of that, we also had probably heavy provider. So does it really make sense to have a subscription for 85 providers when you know some of them will be leaving in the near future? Versus if you pay as you go, it might be a little more expensive, but overall, is it going to be more affordable? Or I think some of the pricing plans are, I think some of that needs to go on the vendor as well. Like they need to make it affordable for FQHCs or safety net environments, and still haven't a way to create revenue.
Model is to extract as much money as possible. That's the company.
Right. So how do you?
That's one of the lowest, you know, that these services are one of the lowest hanging fruits. And then the second line of question, this will be easier, but still tricky. Does every patient know that they're getting an AI written note?
Yes, we did make sure there was informed consent, so
Like written, like
we did have a
Oh my
written
God.
informed consent.
for every single caption?
It was, I think it made its way into our consent to treat packet where they had,
So it was in the screen package.
it was, but that was like after we piloted it, during the pilot, we actually had like laminated things. We would give it to the patient while they're in their room.
So
And then the clinician would ask them like, I use this AI scribing tool. Do you want to opt in or opt out? And then they would also note that in the chart.
what percentage opted out?
None. We had 100% of our patients.
What's the end?
What do you mean? Oh,
And you said that. All right, I remember that. So
Yeah,
what's
so
the end? How many patients?
I don't have that information.
Thousands?
It was over probably 6 months. In Kingman, Arizona. Probably longer than
Oh, my goodness.
that. But still in Kingman, Arizona, we were surprised to see that 100% of the patients opted in. And then to also have positive.
They afraid they weren't gonna get treatment if they didn't opt in.
I hope not.
Yeah.
I hope not.
I don't know, I'm just asking.
Yeah.
I'm thinking out loud.
Yeah.
Bring you up, keep it, to come talk to our North Country now, whatever it is. Yeah, we have some.
We should just get a local server. If we need to build a computer up there and try to do this for $10,000.
Now it's different because now that they've been bought, I don't know what that's gonna look like if they have their own implementation of.
To me, they've been bought because they were in bankruptcy.
Yeah, yeah, they,
Yeah, so El Rio took over yesterday, and the organization is now El Bridge. And they are
So
using
now
a
they've got
different EHR and,
Now they have a new HR, so they're probably.
yeah.
yeah.
they
So my point is more that I think there's a.
So start somewhere else, go somewhere else.
Yeah, there's still a lot of need that I
There's
think,
still like
Yeah.
safety net or private organizations who probably need to learn how to navigate.
It's just a lot of opportunity. Simple thing.
Yeah.
Relatively simple thing. This is not like, reading the nuances of a complex, cancer situation.
No, it's absolutely not.
It's not. It's just trying to get notes written and it's a perfect example of how you can just do this straightforward. It's not.
yeah, the stuff that we've been talking about, like, is up here. And I think in northern Arizona, we're like here. We're like just trying to get stuff off the ground. We're not trying to do creative.
Perfect to wait till Michael comes to tell you what's happening in Asheville.
Yeah.
So it's the perfect, ends of the spectrum. Like, it couldn't be set out any better.
Beautiful, I love that.
It couldn't be said any better, but I feel like, even if we were to have, maybe that's not the right city, but even if we were to have like 25% of a programmer, a computer, and, a test site, we can make a whole lot of good happen.
Yeah.
And it would be so cost efficient as
Yeah.
opposed to a subscription model. You just have to find the right spot. Maybe it's the same place where we're doing the handheld ultrasound, to get, down and dirty ejection fractions. Maybe we just kind of do it all in the same spot. So as predicted, so that was, northern Arizona, and now we're at Harvard Medical School, so you're exact opposite. In the description, I'm so thrilled that Michael came from Boston for this talk, and I do think we're probably going to repeat some of this stuff next year, maybe with a little bit of updates. I've known Michael for a long, long time. I always say, the thing that makes me the most proud of anything in my whole career is the trainees, Leo and Michael being two of them that now, go on to these incredible careers. He's an associate professor at Harvard Medical School. He runs a at least $100 million facility at Mass General Brigham in the cardiac care facility. He's a master imager, and he's also an expert programmer in AI. And he's going to talk to you about risk prediction. So not the, we're going to detect things, but we're actually going to use that information to get more out of the fish or do that type of risk prediction that you otherwise couldn't do. So Michael, thank you for making the trip. And I'm sure, make sure the recording's on, because a lot of people are going to listen to it that are not people on it, right? So.
Yeah, thanks so much, Frankie. And yeah, it's not, we don't have $100 million. So we have grants, but that money goes other places. So it's not ours. It's elsewhere. But yeah, I met Frankie, I guess 20 years ago when I was a med student, and I had, as a med student, I was interested in radiology. I went to work with a cardiac radiologist, Marty Lipton, at Brigham. So now you should talk to this Frankie guy. I did, and that was like hugely successful, at least for me as a med student. It helps launch my career in research. But in any case, so just starting with disclosures. So we do have a number of trials we run. Most of the disclosures are for clinical trials that don't have today. Some of them are for AI grants, like this grant, which is actually the malpractice insurance carrier. Medical school hospitals advise me to go for the AI learning. All the machine learning models I'll talk about today, we use free open source software, so don't have any commercial interest in those. And this is a shout out for our program. So we run the FGH Cardiovascular Imaging Research Center, located next to Mass General Hospital in Boston. This is sort of the center of downtown Boston, almost downtown Boston here. We have 35 people on the group, including about 12 faculty and fellow staff. So the thing I'll focus on today is this idea of, like Frankie mentioned with the salmon, that there's things we diagnose on x-rays, like in this case, there's a here with the cough, has this capacity in the microbial blood. That could be pneumonia, it could be cancer. We're diagnosing that from the x-ray. But in fact, there's a lot of other information on this x-ray. I can tell from the energies in her shoulders that she may, what her age might be. I can tell by the way the lungs are expanded, the shape of the heart, something about obstructive pulmonary disease or emphysema, etc. The idea here is that you could take a simple X-ray and beyond the diagnosis that there's pneumonia, and actually look at its prognosis. What is the risk of having a heart attack? The risk of having lung cancer? Just to talk, maybe even change the way that person's treated based on. Why are we interested in chest X-rays? There are a couple of reasons. Chest X-rays are the most common diagnostic imaging test worldwide. In the US, we do about 100 million a year. Medicare Part B beneficiaries. There's an average of one outpatient chest X-ray per beneficiary each year. Of course, some people are getting a lot of X-rays, some people are getting on an average. The other reason, like when I started doing this, so I'm not a computer programmer. I've done some in the past. It's very hard. We started working with this 17 years ago. It's very hard. We're not programming, so I got a lot of stuff to better this than I do it. But at the time, chest X-rays were very useful to start with because it's a single two-dimensional image as opposed to like the stack of CT images. So it's a relatively small image. It's like segregation. There's also a lot of X-rays out there that are publicly available. Today, you can go out on all the million chest X-rays, either that are completely open, you can just download them, or then you might need a minimal D-way to distribute them when you agree that you're going to distribute them or use them for various purposes, but they're essentially out there and you can scan right now. So there's a huge amount of data out there for chest X-rays, and it's relatively tractable for machine learning, just because it's a single. So the pot, at that time. Oh, sorry. Yeah, just put it next to you, or you can. Okay. Yeah, I'm talking to it. So at that time, this is again like 2017, 2018. The NIH had released this data set called Chest X-ray 14. So it's basically a set of chest X-rays, and they were annotated with 14 diagnoses like pneumonia, low nodule, cardiac leaving heart, pleural effusion, being fluid along the center. So that was sort of the data set everyone was using. And all of these companies were all designing tools that could diagnose pneumonia, could diagnose lung nodules from the chest X-ray. For us, we run a lot of clinical trials. We've asked a lot of long-term outcome data. We've done a lot of studies looking at whether coronary calcium's calcified plaque in the coronary arteries, the amount of fat you have in your body, how that affects your long-term risk of cancer or heart disease. So it seemed natural for us to instead focus on prognosis and risk prediction on these X-rays, because that's what we did. Normal imaging, that was a niche that people really weren't looking at least at that time. So, the underlying hypothesis is this idea that you can predict someone's risk of disease, you can predict someone's biological age from their chest X-ray image. And I have two X-ray images here. This is actually me a couple of years ago, maybe when I was a little thinner. This is my X-ray. And this is another person who's around the same age, their X-ray. And there's some differences you can tell there. If you're a radiologist, certainly. But even now as a radiologist, you can tell, maybe I'm a little thinner than this person because I don't fill the whole X-ray film. My heart may be a different shape and size. I may be able to expand my lungs fully, whereas this person can't expand their lungs fully because they may have a larger belly, they may have lung disease. And then if you look at the spine and the shoulders, you get a sense for how much arthritis or other degenerative changes I might have. When I talk to people about this, I kind of, who aren't radiologists, who aren't medicine, sort of the example I give is like when you walk down the street, or if you meet someone and you shake their hand and say hello, you get a ton of information just from that simple interaction, like how well does someone walk? Can they give you a firm handshake, or is their grip weak? Can they talk without any hesitation? And then again, like what they look like, what their face looks like, the clothing, etc. Now imagine if I showed you 250,000 people, and with each person I told you this person's going to get a heart attack, or this person's going to live to 100, or this person's going to get lung cancer next year. You can imagine, you could probably get a sense from that, just like how, what kind of age or what kind of health that person had from that. And that's really the same thing here. We're showing machine learning models hundreds of thousands of X-rays attached to a diagnosis that they have later, and teaching them how to identify those things that might help predict whether they get lung cancer or heart disease. And how could that be useful? Again, there's that whole idea of using opportunistic screening. I know, certainly there's a concern for alert fatigue with this, but there are some ways that it can be helpful. One is lung cancer screening CT. We get a lot of chest CTs. The new guidelines that the American College of Cardiology and American Heart Association, multiple others, released last month. Again, restating that if you see coronary calcium on a CT scan, you should really consider starting a cholesterol-lowering medication like statin to prevent cardiovascular disease in those patients. So automated ways to identify that calcium can help identify people who should be on a statin. And then from X-rays, identify people who are high risk of lung cancer. You could get those people with the standard screening test, which is the lung cancer screening CT, lung nodules, or to identify people who are high risk of heart disease, cardiovascular disease, again, considering putting them on a statin. So this is the first paper we published looking at this in 2019, using these chest X-rays to predict long-term mortality from chest radiographs. We used a data set. At that time, it wasn't public. It was quite an effort to get access to the X-rays. But we had, in this case, I think it was about 200,000 X-rays from this prostate, lung, colorectal, ovarian cancer screening trial. And one of the lung cancer screening trial, part of that was to see if getting chest X-rays could help identify people who are going to get lung cancer. And that was a negative trial. Chest X-rays don't help diagnose lung cancer, at least in a screening population. But we were able to use those X-rays, the outcomes, identifying who got lung cancer, to train a model. In this case, they also had mortality outcomes to predict when patients would die based on their X-ray. And this graph is a Kaplan-Meier survival curve. You have the percentage of people surviving on the y-axis and the years after the chest X-ray on the x-axis. And then using the AI tool, we could divide people into high risk, which is the green, and the low risk, which is the blue group. You can see the higher risk people, the people in green, more than half of them were dead in 12 years. So this was actually identifying people who were at much higher risk of mortality. And then we saw a similar thing in external validation studies, the National Screening Trial, which is famous for the trial that really validated lung cancer screening CT in heavy smokers. But that trial had a placebo arm or a non-CT arm where they got chest x-rays. We use those chest x-rays, the negative arm, to do this study. And again, here they only had 6-year follow-up, but you're identifying the intensive risk of mortality. And of course, some of this is identifying age and sex, because women live longer than men, and older people die earlier than younger people. But even after you adjust for that and for the findings of the X-ray, this is still identifying people who are high risk of mortality. And here, people often ask, like, what is it looking at? And that's a pretty difficult question. Here are some heat maps that can sort of get to that a little bit. And the way these work is essentially you take an X-ray image, you have a prediction. In this case, it thinks this person's at very high risk. And then you go through and you include, you sort of like black out certain portions of the image. And then you see what the prediction is. So the idea is that the portions of the image that are most important for the prediction, when you black those out, the high risk will turn into low risk. So in this case, it's looking really sort of central heart. It's the person with sort of a larger heart. They have some increased interstitial markings, essentially. Was very high risk and died 2 years later from respiratory disease. This is a person which is considered very low risk. It's looking here sort of at the waist and chest. And this is a younger woman who survived for 10 years. And women on average in the US live somewhere between 5 to 7 years longer than that on average. So sex is a very strong predictor of mortality. And you can tell that from the breast shadow, and also this person's a little skinnier because you can see their waist. And then another case, which I'll focus on a little longer, where it's looking at the sinus and the sternum, where the person had a cardiovascular death. And then this is sort of a nice side. These tools are probably most useful in identifying off-target predictions, meaning the AI model is identifying something that is not really pathologically important, but identifies people who are high risk for some other reason. In this case, I don't know if it projects that well, but they're actually sternotomy wires here. So these are wires that are used after some heart surgery to close the sternum back up. May or may not be able to see that here. So we learned to identify that if you have sternal wires, you're high risk. It makes sense. It doesn't make it particularly useful because this is looking at that. And this is the big, this is one of the, again, like I said, one of the reasons why these heat maps can be useful, because it helps identify off-target predictions. This is a somewhat famous paper where they trained a model to identify pneumonia, and they used patients from 2 different clinics. There was an outpatient clinic where very few patients had pneumonia, and then there was the urgent care where a lot of patients had pneumonia. They developed this tool. It was very accurate in detecting pneumonia. But when they did these heat map classifications, they saw that the heat maps were always making predictions off these things in the corner of the image. Does anyone have an idea what these are? Like this L here. That's the marker that the technologist puts on the X-ray image to show you which side is the left. And so the urgent care clinic, they use one kind of marker. And they kind of use another. And so the actual, it's really an optimization problem. It identified that you only ever see pneumonia when you have a marker that looks like this. So it was using an off-target thing, which, of course, that would break down totally where you use this in another hospital, and it's not going to work in the real world. But this is just sort of a cautionary tale how, the actual is really an optimization problem, trying to get the optimal way to identify pneumonia. In this case, actually, the marker was a very strong predictor of whether this would happen. So that's where these can go. So following that, we did a number of other studies, using a similar path to predict biological age. So we had long-term outcomes from PLCO. We used several different populations to estimate lung disease mortality. We worked with our cardiac surgeons to estimate post-operative mortality after cardiac surgery based on their preoperative chest X-rays, and showed that it worked better than the standard Society of Thoracic Surgeons risk score that we usually use for the stratification. And then in patients who are coming into the emergency department with chest pain, most of those patients get an EKG and a chest X-ray when they roll in, and you can use that to predict who's likely to have dissection, MI, and pulmonary embolism based off that X-ray. So I think moving on a little more to where we think this could be most useful, we applied this again in these clinical trials to predict people who are at high risk of developing lung cancer. So here's something you can do something about. We have lung cancer screening with CT to identify high-risk people. You can make sure that they get lung cancer screening CT. And that's a big problem because even though lung screening CT is free, it has to be free, at least based on the Affordable Care Act. Through all private insurance, it needs to be free for people who meet the screening criteria, which is people who have smoked more than 20 packers of cigarettes and either are currently smoking or quit in the last 15 years. So packers of cigarettes is like if I smoke 1 pack a day for a year, that's 1 pack a year. If I smoke 2 packs a day for 10 years, that's 20 pack years. So if you smoke that much, the guidelines say you should really consider getting lung screening CT. The problem is that nationally, only about 10 to 15% of people who are eligible for lung cancer screening CT get CT, and that's really an abysmal screening rate compared to colon cancer screening or breast cancer screening, which are more like 67%. So there's a lot of room to improve who we screen for lung cancer. And using these AI tools, people get a chest X-ray again for another reason because they had, their knee or they have a cough, maybe a pneumonia, can help us identify people who should be getting lung screening CT. And so similar to those other studies, here this is the rate of lung cancer incidence in the y-axis, the years after the X-ray, the x-axis. And you can see at 6 and 12 years, the AI tool is able to identify people who are at very high risk of lung cancer. And when we compared it, the other thing with these tools, you always want to compare it to the clinical standard because if you're not doing better than the clinical standard, there's no reason to do this more complicated thing. In this case, it did do better than lung cancer screening eligibility criteria, which are widely known to be not that good. It will basically miss 30% fewer lung cancers while screening the same number of people. And then it's always important to externally validate these tools. So these were that was developed in the PLCO and NLC lung cancer screening trials. But those are very artificial situations where volunteers who are volunteering for screening. That's not really necessarily the real world. So we ran this tool at our own hospital, Mass General Brigham, using chest X-rays in 15,000 people, again finding that it was superior to the lung cancer screening criteria, including in women and African American people. And then we had open sourced this model, so a group from Korea approached us to externally validate in their population. In Korea, it's common to get a chest X-ray as part of your annual physical exam. So they had 20,000 people where they ran this tool. And again, it helped identify people who would later go on to have lung cancer better than the screening criteria. So we're currently running a clinical trial where at our primary care clinic, we're running this tool on patients who come in with a history of smoking, and then the tool identifies them at high risk or potentially high risk of lung cancer. We're learning the PCP to make sure they talk about lung cancer screening eligibility. And we have a sub-study in the later stages of IRB review where we'll actually, for those people who the AI tool picks for high risk, but who don't meet that eligibility criteria of smoking 20 packers or quitting within the last 50 years, we'll actually pay for the CT scan for them to see if we can pick up more lung cancers. So I'm not sure this next one is going to work. This is now talking about AI for heart risk and stroke prediction. Let's see if the audio works.
So let's talk about this study, right? The chest X-ray study. So this actually was not published yet, right? It hasn't been peer reviewed. It's very preliminary. It was presented at a radiology meeting. So I want to caveat that with saying that. But it is a proof of concept. And the idea that you can take a single chest X-ray. So many of us have chest X-rays in our lives and actually use it to predict risk. So what the researchers did is they looked at 150,000 chest X-rays and developed a AI model to predict it. But then they said, let's test this. So they took 11,000 patients and they used that chest x-ray risk model, and they found that actually correlated very well with the patients that then went on to have an actual heart attack or stroke. So there was a real association there. And then they compared it to that risk calculator that I mentioned, and it correlated well with that. In fact, it added information to that. So really the beauty of this, if it proves to be true, is that yes, one x-ray, which is very ubiquitous, could potentially help in the sense that you could actually get a report that says, okay, your chest x-ray is clear, but you're at increased risk of cardiovascular disease. Go talk to your doctor or your cardiac.
Sorry, I like to play that because they do a better job of hiding something. But that came out when we presented this in RCA years ago, and the paper later came out in the House of Medicine. Again, a similar story. You can train a model to predict someone's risk of heart attack and stroke based just on their chest x-ray. And here's these incidence curves of the risk of MACE, that's major adverse cardiovascular events in heart attack and stroke, on the y-axis, and then the years after the x-ray on the x-axis. And this is this is a master Reagan population. You can see, you can identify some people who have like an 18% risk of having a heart attack and stroke in 10 years, so it's significant risk. You really need to be in treatment. Yes, this is another use for this, and again, like with all models, we want to compare this to the clinical standards. So that at that time, the clinical standard was the whole cohort equations that predict your 10-year risk based on your age, your sex, your blood pressure, your cholesterol, etc. So we're able to help improve on that, and also to who are getting episodic care or hospital caring for broken bone, we don't get primary care with us. This is another, and may not have the cholesterol in the system. This is another way to identify people who might otherwise slip through the cracks. So that's a lot of the work we've done on chest x-rays. I'm going to switch gears now and talk about CT scans. So here's some work we did a while ago, automating coronary artery calcium scoring on chest CT. So now, as of today, there's probably like at least 10 different vendors who FDA or CE marked approved tools that do this. This is like kind of been done. But at that time, this was really the first open source tool to do that. And it came down to a segmentation task. When I say segmentation, it means when you have a CT scan like this, you're going to teach the model to mark down things in this blue circle are the heart, and things with the red in it, those are its coronary calcium. So that kind of task AI is very good at. So you're able to train that model using 1,600 individuals from the Cranium Heart Study, and then tested it in a number of other clinical trials. And we found that when we compared humans to the actual, they weren't perfectly correlated, but correlated pretty well. And then if you look at the again, these Kaplan-Meier curves, so you have the risk of cardiovascular death here on the y-axis, and the years after the CT scan on the x-axis. And people with more calcium are at high risk of cardiovascular death, as you might expect. This is work being done at Stanford, not by us, but they have a trial called Notify-1 that came out a few years ago. So in this trial, they had another tool, a commercial tool, which they ran on all of the non-contrast chest CTs that were done, and they identified people who were statin naive, meaning they were taking a cholesterol medication, had coronary calcium on these CT scans. And I thought this was the outcome, and then they notified the patients and the clinicians to compare those patients, and the primary outcome was whether that person was on a statin 6 months later. And as a radiologist, I thought this was kind of aggressive, but maybe not run this out there. But how they did this is they actually sent an email to the care physician. And obviously, primary care physicians are very busy. They have to see this email. If they didn't get a response 2 weeks later, they directly emailed the patient. And what they did is they gave them an image of their CT scan with the coronary calcium circled, and actually a radiologist double checked this is correct. Each of these, and they said, you have plaque in your arteries, you should talk about starting with statin. And that's very powerful, one for catching people again slip through the cracks, but there's also a lot of data out there by showing people their own plaque, like pictures of their own plaque, That's very helpful for convincing people to start on the statin, because many people who, maybe should be on a statin, the majority of them probably don't want to be on a statin, or even if you discuss it with them, they decide not to be on it because they like to get medication, which is totally understandable. But by giving them, an image and picture of what's in their artery, that can really help motivate people to actually start and stick with this kind of therapy. I think that's very timely because like I said earlier, the 2026 multi-society guidelines for management of lymphedema just came out last month. And coronary calcium scoring figures prominently in that. Essentially, for the medical students here, the guidelines, the two big changes, number one, well, there's a lot of changes, but on this figure, I think the first thing is that the pooled cohort equations, the tool we use to predict 10-year cardiovascular risk and guide who should be on a statin, that's been superseded now by the PROMET score. So that's another kind of score that predicts 10-year risk. And basically the main difference between those two is the PCE was based on a lot of historical populations from the last century, I guess. And the PROMET score is much more modern population, much lower burden of atherosclerotic disease and cardiovascular events than the historical populations. So that's one change. And then for people with borderline PROMET score, 2.5 to 10%, or so 5 to 10%. If the person is unsure whether they should start a statin, which is probably like a lot of people, you can opt to do a coronary calcium score to sort of gauge how much plaque there is and guide their risk. And the guidelines are that if the coronary calcium score is 0, the person's at very low risk, very low 10-year risk, and statins can be withheld for a certain amount of time, usually around 5 years or so. And then if the coronary calcium score is greater than 100, or greater than 75th percentile for age and sex, then the person should start on the statin. So that's, calcium is becoming a bigger and bigger part of primary prevention in cardiology and in medicine, and we now do a ton of coronary calcium studies. So moving on to CT, so simply there's a lot more image on CT and X-rays. It becomes a more challenging problem though, because now you get a stack, maybe you have 300 or 400 images. Each of those images is typically 512 by 500 pixels. So you have a lot more, there's just a lot more information for the CT scan than there is on the X-ray. And practically using that for machine learning models is more difficult because you're limited by the amount of RAM on the graphics card. You may not be able to hold as many CT scans on that as you would X-rays unless you use tricks to reduce the size of the images. But here's one study, a pre-med student in our lab, Daniel, recently published, where they segmented out the aorta and heart using an open source tool called Segmentator. And so with that, they could get the shape of the aorta and the shape of the heart. And then they used a technique called radiomics to see if there were certain shapes or configurations of the heart and the aorta which help predict people who would go on to have at-risk cardiovascular events. So similar to some of other studies, we trained it one data set, and then we experimentally validated another data set. And again, in this case, we were able to predict major at-risk cardiovascular events beyond standard clinical risk scores and beyond the coronary calcium score. Here, some more information from that. We worked with several collaborators in Germany, and there are two big data sets here. There's one called the UK Biobank. So for those who are familiar, this is a large database of volunteers in the United Kingdom and in England. We have volunteers to give their genetic information, and many of them have done multiple kinds of imaging too. So here we're using the whole body MRIs in 34,000 people from the UK Biobank and segmenting out the different body components. So you have the subcutaneous adipose tissue, that's the fat in the skin, the visceral adipose tissue, that's the, people like call it the back fat, that's the fat sort of inside your belly around the organs. We also have the skeletal muscle, skeletal muscle fraction, and the intramuscular adipose tissue or fat within the muscle. you think of that, if you buy like, you buy a steak, it's about a marbling in the muscle, and generally, what you find is the more visceral fat that is fat around the organs in the belly, and also the fat inside the muscle, those are both associated with incident diabetes and cardiovascular disease. So that was in the UK Biobank and working on similar studies in another population cohort in Germany called the German National Cohort as well. Switching gears to a separate, this is about a paper that we just published last week. So we'll think of another chest structure called the thymus. The thymus is a structure that sits in front of the heart, or sort of above in front of the heart. It's related to a lot of immune function. It's quite large in babies, but it involutes or gets smaller and smaller as you go through puberty and young adulthood. And then as an adult, many younger adults, like in their 30s or below, will still have some thymus left. By the time you get near 50, 60 or older, there's almost nothing left. So for a long time, that's been thought of as like a vestigial organ. It's really important. This is an interesting study that came out in 2023 from Western, not from us, where they took patients who had that thymectomy, meaning the patient had surgery that took out the thymus, usually because they're doing some heart surgery, the thymus was taken out to get a better look at the surgical field. And they compared it to people who have had other cardiac surgeries but didn't get their thymus taken out. And it was really interesting. What they found is that the people who had their thymus taken out, which is the thymectomy, I think here in red, had a lower rate of mortality and a lower rate of cancer. So the patients who had thymectomy had more risk of death, more risk of cancer than the controls who did not have it. So that was a interesting study to show that, or suggested that the thymus is important. And perhaps we shouldn't be taking it out routinely unless there's a good reason why the person has. So there's some more collaborators from the Brigham University group. They a radiology resident there, Simon Bernatz, did this trial where they developed a machine learning tool to identify how much residual thymus there was on chest CTs. So this is the heart here, and this area outlined in orange here is thymus. So this person has a lot of thymus left. This person has less thymus left, and this person, the thymus has almost completely been replaced by fat. The darker stuff is lower density on CT, so that's fat, and the brighter stuff is higher density. That's soft tissue, soft tissue. So we trained this model in a lot of the CT data sets I mentioned earlier, and then applied it to see, what, based on how much soft tissue was left, how much soft tissue in the thymic bed was left, what was the risk of incident cancer, incident cardiovascular disease. And for the radiologists in the room, you know that the amount of residual thymus you have left is heavily dependent on your age and sex. Women typically have a little more thymus than men, but there was still, even at different ages and sexes, there was still wide variation. This here is age, and then by sex. There's still wide variation how much thymic tissue is left. But even older people having thymus, and some younger people having very little thymus. So interesting, like that paper by Rushesh with thymectomy, we found that the more thymus you have left, actually the lower your risk of developing lung cancer. And that was in the national screening trial that where we had lung cancer outcomes. And similarly, in the Framingham Heart study, cardiovascular prevention study, the more thymus you have left, the lower your risk of having a cardiovascular event. So in these cases, the high, they call this high thymic health, but that really is like more soft tissue in the thymus. So we had a lower risk of developing lung cancer with lung cancer risk of y-axis than the people who had very little thymus, and likewise in Framingham for cardiovascular events. And even after you adjust for age and sex and smoking, with adjusted hazard ratios here, the amount of fibrin tissue that remained, the more times you had, the better off you were. So that was interesting. But just, again, this is, yes, this paper got in Nature, which is, pretty remarkable. It's a very difficult journal to get into, but not that many radiology papers to get into Nature. And I think the reason here, or AI papers for that matter, but I think the reason here, the AI, it's not really about AI. It's really using AI as a tool in the sense that like quantify how much time is left in a lot of people, and the rest of the paper is sort of like a normal sort of pathophysiology or epidemiology study. So while it is about AI, it's using AI as a tool rather than sort of like as a means rather than that. All right, so those are most of the studies with AI I had prepared today. I thought I might take a few minutes to talk about some things that came out recently that I think maybe is of interest to a wider audience, and those are sort of radiology, cardiology studies, or oncology studies. This is more of general interest. I certainly think there's a lot of promise with AI, but we still have to prove that these tools work and that the expense and complexity of implementing them warrants their use. So this is a study that came out of JAMA, I think it was yesterday, came out of JAMA yesterday. And what they did is they had 5 different sites, including Mass General, where they had implemented an AI scribe to basically record a conversation, record notes during outpatient visits. And so it was 5 sites using 3 different AI scribe vendors, all through using the Epic EHR. And what they did in this study is they had a pre- and a post-intervention phase, and then they introduced this AI scribe tool, and then some people used the scribe and some didn't. So they compared people who used the scribe to people who didn't, and among the people who used the scribe, sort of before and after they started to use it. And the main outcomes here were the total time in the EHR, and then the total time in the EHR outside working hours. And then both these 3 measures, so EHR time, documentation time, any time actually like documenting stuff in the EHR, and then time outside of work. And those were all those times were normalized to an 8 scheduled patient hour a day. So that's sort of the unit here. And then the last outcome was the number of ambulatory visits the person had in a given week. And if you look at that, it's a little small here, but you have your scribe adopters here, and you have your scribe non-adopters. And these are in minutes here. So I think if you look here, I'll maybe just focus here on this one. So this is the difference between the adopters and non-adopters pre and post AI scribe intervention. So essentially, the total EHR time decreased by 13 minutes per 8-hour patient day in the AI scribe adopters. The total time documented was 16 minutes, and the total time outside working hours was 3.5 minutes. And the people who adopted the AI scribe saw half a patient more each week. And so I think this is interesting. I think so. On one hand, there's like a statistically significant result. So here's an adjusted result of this. So you are saving time with the AI scribe, yes. But I guess the counter to that is that the amount of time saved is not that much, and that needs to be considered. When you're costing out all these things, and there are other things that go into this too. Of course, perhaps at our hospital we don't have. That's not true, but at least in this population, there weren't like in-person scribes doing this. That wasn't in person. But that has to be considered when you're considering these tools. There's a nice editorial that came along with this tool too as well, and these are the outcomes they measured in the study. The things they didn't measure were like, among the people who adopted this, they have less burnout because they had this AI tool. Were they able to focus on other, they may have been in the EHR, but maybe they were spending more time, more quality time, like documenting the right thing or the wrong thing. You know, that isn't detracting at all. It's really just the absolute time. Sorry, that's the question.
Yeah, I'm noticing everybody saw less patients at the end of this study. And it looks like, you know, pretty drop across them, 0.8 for the non-adopters and then 1.5 for the adopters. Were they notified that they were part of the study?
Yeah, so they were. And I think also there probably also some just time period things too, because these were at a different time period, so 6 weeks before and 6 weeks after. And you know, I know from our clinical schedule, if you just take a random 1 week period, another random 1 week period, there's a huge amount of variation how much work gets done just based on, you know, vacations, holidays, or referring physicians, like what their schedules are, school vacations, all these things. So that's why we're looking at the differences probably more.
I do have another thought, since we talked about this last night. I'm being careful because we're recording this. I think a lot of people are going to listen to it later. But the results from one EHR might be different than another EHR versus no EHR. And so there might be a factor there, depending on what you're starting from.
Yeah, that's certainly true. These were all using the same vendor's EHR, but that EHR, as you know, is customized for different places, somewhat. And certainly how different clinics work may be different than others.
There might be more meat on the bone, the game, you know.
Yeah,
And it might be.
I didn't include that here, but in some analyses, you might think like trainees, primary care physicians, women, they broke down like some groups maybe derived a little more benefit than others. I think probably the primary care physician trainees. In primary care is probably where it's needed the most, and the you know, the type of discussion, the nature of the discussion may be different than like in clinic, for instance. You know, so that there was some variability between different kinds of visits, and it may be greater in certain settings versus others. And there's the whole thing with the trainees who, you know, our trainees use these systems a lot. Like in radiology, we have an auto impression tool, which like reads through your report and auto generates impression. We actually decided to turn that off for the residents because we don't want them to get too dependent on that. You know, you can debate whether that is a good thing or not. But there is, you know, on one hand, I think they probably benefit the most from that. On the other hand, it may or may not be good because then it can be functional without the SRI. That's another question.
I mean, no matter what, 16 minutes is extremely underwhelming.
Yes, so I think it's less than people might have hoped for. I mean, certainly 16 minutes is like half a visit or one visit, and that, you know, if you think of all the other things that go into that, that could be, you could, I mean, it all depends on what it costs and will take this. That's, yeah, but I think I would have hoped that it would be. Okay, so this paper is out there. It's really available if you want to take a look. It's been in the press quite a bit. It just came out yesterday. And here's a similar study. So in radiology, you know, we have the amount of imaging that gets done really exceeds the number of radiologists who read it. And that's true in the US, but I think that's really true in other countries that even have fewer radiologists. This is a study from the UK where they used an AI tool as a triage tool. So basically, you get a chest X-ray. This AI tool looks over it, and if it thinks you're at high risk or you might have lung cancer, it says read this chest X-ray first. And if it doesn't, then it doesn't. And all the X-rays eventually get read. In this case, it was read by another AI tool from the same company and also a human radiologist. But the idea of the study was to, you know, because patients might be waiting quite a few days before they get open X-ray, the idea is by triaging them, you can get people who are at highest risk of really have lung cancer concerning findings, you can get them into the care pathway faster using this triage tool. So what they did is they had about 100,000 people, and I think it was 5 centers in the UK where they ran this tool. And what they found is that 550 of those, 0.6% of the x-rays, those patients actually had new lung cancer. And the hope was that it would reduce the time to diagnose the lung cancer by using the triage tools. The patients were waiting like 3 or 4 weeks to get their x-ray results. But in this study also that did not happen. So with the AI tool, median time to diagnosis was 44 days. And without the AI tool, it was 46 days, and that was not a significant difference. Yeah, so at least in this setting, the AI prioritization really did improve the time to diagnosis for lung cancer. So I just present these two. I think there's a lot. Again, there's a lot of promise for applying AI in medicine and imaging. But I think it's really necessary to prove that there's an actual benefit, particularly with the tools you have to pay for. And it's not just that you have to pay for it, but you pay for this, you can't pay for something else. So it's really important to make sure that it makes sense in terms of the patient outcomes. All right. So those are most of the things. I wanted to switch gears a little to what most of our group actually works on, which is clinical trials. We lead a clinical trials group who does multi-center NIH industry-funded trials, doing coronary CT. And a lot of our trials recently are using this idea that you can see plaque on the coronary CT, not just calcified plaque, but non-calcified plaque. And based on the density of the plaque, like this image here on the right, you can assign plaque to non-calcified components, calcified components, or things in between. And the idea that a lot of these trials have used is that you can take patients, and this is a study from the PREVE trial. It was a trial of atorvastatin in people with HIV to prevent heart attack and stroke. The idea is that by taking a CT scan at baseline, and then after 2 years of placebo or drug, you can actually track how plaques changed in response to that therapy. So in this case, here's a patient on placebo in the upper left, an entry, and this is the right coronary artery, and there are 2 coronary plaques outlined in blue here. And after 2 years, those plaques have got bigger. You can see that here. Here's another patient with a plaque in the left anterior descending coronary artery. The plaque is rather large, but after 2 years on statin, it has decreased in size. So those are the kind of things we're trying to find in these trials. And I mentioned this because, how do we do this? We have tools that are so-called semi-automated plaque quantification that it goes through and a tool tries to define where the inner lumen of the artery is and the outer wall. But in reality, it requires an enormous amount of manual effort, basically drawing hundreds or thousands of circles through the coronary artery to quantify the plaque. But now increasingly we're using AI to help streamline that process. A human is still looking it over, but the automated part of the segmentation is much faster. And there's another trial we're starting, I hope next month, about 25 sites in the United States, where we take younger persons, being 11 to 40 to 60, and 30 to 50, who may be at risk of coronary disease, who may have coronary calcium, and then we're randomizing them to a 1,500 patient randomized trial where they either get suvastatin, a cholesterol-lowering medication, colchicine, an anti-inflammatory medication, or placebo, or one of those combinations to see whether 2 years of that treatment can reduce coronary plaques. So we'll be starting that soon. And we'll actually be using AI for some of the plaque modification. All right, so that's what I had today. Maybe now's a good time for questions.
Diagnostic correlation with like 0.94 was very high.
And,
yeah, and it was very interesting with that, comparing that to what Theo had said earlier about how poorly some of these AI tools can actually diagnose. Is that just because of the type of imaging, like that was
So,
okay.
One question is like, is it one or not? But this one is more of a segmentation problem. And calcium scoring is a particularly, I don't want to say easy, but maybe simple question, because we have very clear definitions for what calcium is. It has to be a pencil that's over 130 ounce units with a certain density. And so you can actually just mask that out pretty well. And then counting that is, it's just an easier problem to do. So I think that's why a lot of these segmentation tasks have been easier for me to handle. We clinically now we're actually using an AI-assisted calcium scoring tool for all of our coding entities. And it's not the one we developed, it's the taper tool developed. But I would say it's generally pretty good. I would say it's like 100% right 85% of the time. 10% of the time it's like a little wrong, like it might be a few points. It doesn't really make a difference in terms of the outcome. But then 5% of the time it is like really wrong. It's making a difference in how efficiency is treated. So it's important, with all these things. The nice thing about calcium is this tool, like they said, it actually outputs the image series where it shows you which parts it outputs. You can check. And it's really important to do that because again, 5% maybe it's really making a big mistake. And you catch that, and you can do that because you can see the outputs. So I think that kind of task is maybe a little easier. It's just an easier task. Right at the
Are you presenting to the people with the money with these presentations? Like, are they seeing this before they invest 500 billion or 50, whatever billion they Amazon and can't remember the three big companies that just put into I think you were spoken to AI. Are they seeing this information before they're just throwing money at these AI technologies? So, is it going in the right direction?
I think a lot of the money going right now is not necessarily, it's more of a promise of something. I don't know that these, none of the tools here are made by those huge corporations. I think certainly like that paper from JAMA, the Nature Medicine about the chest x-rays, I think that, thinking on a smaller scale, hospitals, thinking about purchasing this, does that make sense? But then I think it's something they're really looking at. I would say though, OpenAI and, these other companies, I don't think the money is being spent because they're proven result. It's really like a promise of something that's going to happen. I don't really know how much this will manage them, to be honest.
It seems like this is such a better use of what you're doing and what you're showing, especially if it can help everybody, it seems like.
In the funding landscape, federally has changed quite a bit. My research is on LGBT health, so that's just like gone. That's still not funded until there's a change in administration. But AI has become a priority for NIH. Are you hearing from program officers or from other people that they're really excited about the kind of work where funding is?
There has been funding for AI related things. So, certainly we've seen that a lot. A lot of the work we've done with HIV and that whole area has been estimated recently. But related to AI, I would say as a grant reviewer, do you see a lot of proposals with AI? I don't know if it's really, unless it's a specific RFP for AI, I don't know if that's really necessarily favorably or less favorably looked at. But I will say, using AI as a tool, to do something, particularly if you can do that cheaper, or so you can spend money on patient recruitment. I think I see that a lot, and I think the idea before, maybe if you said you're going to use an AI tool to measure calcium, I think people would say that's a stretch, that's good work. We're not really on that. But now I think there's more acceptance that stuff may work. It's something more reasonable to do. So I don't know if that answers your question, but I think it is. Well, thanks everyone for listening.
So at the last second, I just did the survey. It's only 4 questions, so please do it.
Yes, if you could just take a minute. This is just if you have an idea that came up during this workshop that you'd like to see us explore, maybe some more on, that question's in there. But we'd love your feedback. We're always trying to come up with new ideas, and we're actually posing another 5 workshops for next year's academic year. And so, any input, especially, I feel like this is such an important topic. It's moving very fast. I think at that December ASU workshop, they said this is going to be like a 3 to 5 year tech boom. And so I think we're already in year one with this. And so I think a lot of exciting changes are coming. But thank you all so much for coming today. Thank you to Frankie, Leo, Brianna, and Michael. Really appreciate all the support and contributions you made to this workshop. Please grab some lunch on the way out. I've got on the right side, we have some vegetarian options. I think there was one or two of y'all that expressed that you were vegetarian. But yeah, thanks again for coming. And I will probably have this video edited and up on our Share YouTube channel sometime next week. I'll send out an email to everyone that came today, just with the links to that. And we also have some great other workshops on there too. Like I said, we've been doing this for 8-9 years now. And so some of the workshops are a little dated now. They've changed, especially post-COVID. But yeah, just a great resource. Please share that with whoever you think. But thanks again for coming. Safe travels if you are not in there. Safe travels anyway, going home. I really appreciate it.
Thank you.